distinguished speaker, colleagues, ladies and gentlemen. A very good morning to everyone, and thank you for joining us at the online symposium titled COVID-19 Pandemic, Current Research and the Role of International Collaboration. This symposium is certainly a special occasion for listen to the update on COVID-19. It will be an occasion to listen, to discuss, to share information, and to plan for the future. We have about 100 participants. Gathered here today. I also welcome the colleagues from United Kingdom, Germany, China, India, Ghana, that have also honored us with their presence. Their presence is also an opportunity to establish a new scientific and professional bridge with other geographical realities. As you see, this is the map to show the participants and the presenters from different localities in the world. The Egyptian Society of Virology is active for many years. It is established in 2000s, and the location of the Egyptian Society of Virology in Cairo, and we make many international conferences. This year we prepare for the 8th international conference, but unfortunately it is postponed till the next November. We prepare a local scientific community for the outbreak situation, as well as help in eliminating neglected diseases. For example, we make seminars for the next viral pandemic story from ongoing world epidemics. As you see, it was in March 22, 2017. This year in February, we organized the first symposium or consortium for rabies out here in Egypt, and it was very successful by the participating WHO, FAO, and Ministry of Health, Ministry of Agriculture. It was organized at the Faculty of Veterinary Medicine in Cairo University. The organization committee has done fantastic work, preparation symposium, and I would like to thank them for their energy, competence, and professionalism during the organization process. For sure, the success I anticipate this symposium will certainly be a result of effective collaboration. I would like to make special thanks to the University of Leipzig for their scientific and technical cooperation. Special thanks to Dr. Ahmed for organizing this symposium with the Society of Egyptians, with the Egyptian Society of Virology. Thank you. Next year, we hope that the 8th International Conference will be located in the same time if we get rid of coronavirus. We hope it will be in Hurghada, as you see, one of the fantastic cities on the Red Sea. Enjoy the symposium, online symposium, COVID-19 Pandemic, Current Research and Role of International Collaboration, 25 November to 22, organized by the Society of Virology and University of Leipzig, Germany. Thank you.
Thank you, Professor Shalaby, for this nice introduction. So now we will start the meeting officially, and I would like to ask Professor Shalaby to make mute off and camera off, because we have the next speaker already waiting for us. And here I would like to welcome Professor Dr. Daniel Bausch. He is the head of the director of the UK Public Health Rapid Support Team. He was a part of the WHO, and he is heading the scientific program of the American Society of Tropical Medicine and Hygiene meeting. And I must say, all the time I say this, if you would like to see a real scientific meeting with real engagement, you must attend at least one in your life, the meeting of the American Society of Tropical Medicine and Hygiene. So, Daniel, now you can share your screen and you can start your presentation.
Great, thank you, Ahmed, and thanks all for having me this morning. Really looking forward to talking. Let me just see if I can get my screen up here. And I believe you should be seeing my screen now, is correct?
Yes, everything is correct. We see you on the screen.
Great, thank you all. So before we in the course of the conference get in specifically to COVID, I thought I would talk a little bit about the big picture of the international outbreak response, the architecture for outbreak response, and then just a few words on the team that I'm privileged to direct, which is the UK Public Health Rapid Support Team, which is the primary entity in the United Kingdom for outbreak response overseas. So, of course, we know that outbreaks have been with us and continue to be with us and will continue to be with us, big and small, and we're focused on COVID-19. It's certainly not the last thing that will afflict our society. And so, of course, prior to this and my team dealing with a lot of other things at the same time, COVID, of course, very engaged, but Ebola and many other things that go on at the same time. And people tend to, from an outside perspective, tend to, think of outbreak response that comes, especially from overseas, as being very dramatic, and these sorts of books and movies, and that show people flying in spacesuits and doing that sort of thing. That is really not what we do, and nor what we want to do. So the outbreak response really should not be based primarily on overseas support, that is technical support that comes just for a very limited period of time. That's necessary, so it's not to say that that shouldn't happen or that we shouldn't have overseas and technical support from various groups, but really it shouldn't be based on that. And we're seeing that the landscape is really changing. So I've been involved in outbreak response for the last, 25 years or so. You can probably tell by my accent that I'm American originally, although I live and work in between Geneva, Switzerland, and London these days. But starting out maybe 20 or 25 years ago, there was this expectation when I worked with US CDC, we would come into an Ebola outbreak and essentially sort of take over. And it wasn't really through an intentional colonial attitude or anything. It was just the expectation that we had the expertise. But we're really seeing that change now, where national stakeholders are really demanding greater control of the response of operations and research. And that's completely appropriate. And as we see that the capacity grows throughout the world, we're seeing that national stakeholders say, okay, no, it's not the US CDC or a team from the UK or from Geneva or WHO or wherever else. It's the Ministry of Health in country that is going to direct outbreak response. And that's completely appropriate. It can be difficult at times because still in some countries, the capacity for implementation may be very thin, but nevertheless, we're seeing that emerging leadership, and that's an important thing, but there are still ways to go. And if you look at this pyramid here on the slide for coordination and implementation, this is really how it has been set up over the years, with the international coordination coming from the World Health Organization that is headquartered here in Geneva, from where I'm talking to you today. And then regional offices for Africa and many others from WHO, but also other regional players, especially these days. So Africa CDC coming onto the scene in very recently, the last few years, based in Addis Ababa, and then growing national public health institutions. and the ministries of health, of course, in many countries. And so we're seeing that those, some of them growing to be very efficient organizations. The Nigeria CDC, for example, was one example. And then that needs to trickle down to local implementation through local authorities and clinical services, and then ultimately to community partners. The problem and where we need to see some restructuring, I think, from this sort of operation is that it still continues to be too top heavy. I think there's still too much emphasis on the top part of the pyramid and not on the bottom part with the community partners. And having been involved in all sorts of outbreaks over the years, I can tell you really the key thing and what ultimately stops any outbreak is the local community. And so you need that buy-in from the community as a partner, and you need them to be engaged and to believe in the mission and not have it be something that is perceived as coming from outside partners that they have to do, that may seem very foreign and dictatorial to them. And so we need to really continue to move the operations down to the community level, and also to make sure that we have more local and regional representation and control of this process. And we are seeing that Africa CDC, as I mentioned, has been really made quite a lot of gains in this area. It's not only about the organization of the response, it's about many other things. So if we look, for example, at the supply chains that have been so fractured because of COVID-19, and we look in the continent of Africa in places that actually produce themselves vaccines, for example, or produce themselves medications. Out of the 52 countries in Africa, there are very, very few, just a small handful that have any vaccine production, of course, within the continent. In South Africa, and small production of yellow fever vaccine in Senegal, or there may be something in Egypt, I don't know, but it's a very small number. And so we're seeing that it's not only the organization, but it's also the production capacity and supply chain that needs to be regionalized and localized in order for effective response in the future. And fortunately, I think there's great cause for optimism as we see the regional production and the regional leadership. And I've put up just a few names here of colleagues and friends of mine that I'm privileged to work with and doing great things. Dr. Chikwe Ikwezu, who directs the Nigeria CDC, John Nkengasong, director of Africa CDC, Shidi Mweti, the director of Afro. And so we're really seeing leadership and growing institutional and regional leadership that gives great promise, I think, across sub-Saharan Africa. We still have the system and still need a system that is generated from coordination on a higher level. And so there's through WHO, the Global Outbreak Alert and Response Network. This is the organization that helps WHO and theoretically at least other partners put expertise into the field when outbreaks happen and countries request it. And just since time is short, a few slides here, and I'd like to make sure we have enough time for discussion or questions if that's appropriate, Ahmed. But a few slides here on what we do. I direct the UK Public Health Rapid Support Team. First of all, you'll note that we didn't call it a rapid response team, but a support team to really underscore the idea that we're not here to take over. We're here to support national and regional entities in outbreak response and with the technical expertise and that they need. And so we're a supportive organization. We're led and co-led actually by, it's an academic government collaboration. So Public Health England, which is the UK government, and then the London School of Hygiene and Tropical Medicine, with which you're probably all familiar with, and then an academic consortium of various partners funded by the UK. We're a team that works specifically in low and middle income countries. So our job is not to address outbreaks in the United Kingdom, for example. It's specifically for countries overseas. And recognizing that not only are outbreaks important, of course, to prevent and to control for public health reasons, for obvious reasons, but there are also opportunities, and sometimes our only opportunities, to really learn about the pathogen and the best ways to control things. And so the way we put together our program is not only for response, but also research and for capacity development. On the research side, we can all understand, one of my roles, for example, is I'm the co-principal investigator for a trial of an Ebola vaccine in the Congo. in a very difficult area of the Congo to work in North Kivu and Eastern DRC over the last few years. And that's really challenging. And people say, well, why would you try to do a vaccine trial in that area? And I answer that, of course, it's extremely difficult, but what are our choices, right? There's no recognized endemic transmission of Ebola, for example. It doesn't tend to happen in places with great infrastructure. So our only choice, of course, is to have research put in place during the outbreak. And so those are challenging but important moments, really, in order to learn what we can. And if we miss them, then the next outbreak, we're really at the same situation and starting again with no more evidence. And then, of course, it's important ultimately that there's capacity development, that it's not only something that we do during the moment when an outbreak is happening, but we're contributing to prevent outbreaks from happening in the future. So if you will, our group strives to put out the fire when it happens, then ask the questions, what were the knowledge gaps that allowed the fire to begin, and then with local partners try to put research in place to address those knowledge gaps and answer the questions, and then work long-term in order to prevent the fire from starting again. This is a look at our team, a relatively small team of around 35 people, including the admin and logistics support. But as you would expect, epidemiologists, laboratory microbiologists, social scientists, clinical researchers, IPC, data science, and then training is an important element of this. And I won't go into too much detail for lack of time. This is just an idea of different places and diseases where we have deployed this is a relatively new team. We just started a little over 4 years ago, just had our 4-year anniversary. So this was set up after the large outbreak of Ebola in West Africa. And so in that time, we've deployed around 15 times or so to different countries. And we deploy, of course, where people ask us to deploy. So that can be either WHO that ask for support, or it can be the government themselves, the Ministry of Health that asks our government. And so we've deployed for a lot for the Ebola outbreaks in DRC, but cholera and acute watery diarrhea in Ethiopia, diphtheria in Bangladesh. Presently have team members in various places around the world, and in Bangladesh working on a seroepidemiology study for COVID-19 in Cox's Bazar, for example, capacity building for COVID-19 diagnostics and detection in the Gambia, and various other projects. Some of this, of course, is in-person deployment. Because of COVID-19 in the last 6 months, much of it has been through more remote working, but it's a mix of different things. We also, I won't have time to go into the research program, but we have over 25 or perhaps 30 now different research studies that have been implemented over the 4 years, with 5 main themes you can see here, focusing on epidemiology, patient-centered research that has been led by our colleagues at Oxford University, microbiology, social science, mental health and well-being, quite a few different protocols that are ongoing. And some of those are more pathogen-based, but some of them are very operationally focused to figure out how we put together systems and enhance really the ability to respond to these threats. And then just a few last slides. I like to quote James Bryce, the British statesman, who said, "Medicine is the only profession that labors incessantly to destroy the reason for its existence." That is indeed what we strive to do. And so what we'd like to do with our capacity development is that over time, people would say, why would anyone need someone from London or Geneva or Atlanta or wherever it may be to attend to an outbreak overseas? They have their own capacity to attend to an outbreak in Nigeria or Congo or wherever it may be. Doesn't mean, again, that we're not there to support, and doesn't mean that there still won't be collaborations for research and science, but ultimately we need to have this not dependent on anyone flying in. One of the challenges, however, is that we can't think that it's just about biomedical innovation and having the teams to respond. There are human rights issues that underlie most of the outbreaks that happen across the world. This is an example. If you look prior to COVID-19, most people would have said that the biggest problem in the world in terms of outbreaks was Ebola and DRC. And of course, it was a big problem. Fortunately, the most recent outbreak there just ended last week. But really during that time, we had over 1 million cases, and these are actually old numbers. It's quite a few more than this now, but and 7,000 deaths in Yemen in But nevertheless, this is not, these sorts of outbreaks are not things that are easily approachable because of the insecurity in these really difficult settings. So it's not just about biomedical innovation and just about being a biomedical scientist or a doctor or whatever it may be, but we have to advocate for health as a human right on the social and political levels as well, really to get to the bottom of this. And one example might be that if you look at the places and the diseases for which my team has deployed over the last 4 years, about half of those outbreaks are diseases for which there's a vaccine. And so when you think about that, really the solution is already there. It's just the solution has not gotten trickled down to the people who really need it. And that's not about not having the biomedical product. It's about the impediments on a greater level with social and political elements. I'll end just with a few last slides. One of the things that we're doing at London School is creating a Center for Epidemic Preparedness and Response. And this is something that we recognize, as I mentioned, it's not only about the biomedical part of the response. We need to bring together the people who work in the more traditional laboratory sciences and epidemiologists, but we also need to bring together people with expertise in health economics and social sciences and political sciences and policy, and to really bring together. And so we don't get again into this extremely difficult situation that the world is in right now, where we're balancing our economic fortunes with our more classic health fortunes and trying to figure out which way to go. And so that's one of the things we hope to move forward on through the London School. And then thanks Ahmed for mentioning this early on. So as Ahmed mentioned, I've been for the last 6 years the scientific program chair for the American Society of Tropical Medicine and Hygiene, now the president-elect for the society. And we just had our annual meeting last week, all online. Hope some of you were able to tune into that. We hope to have it in person next year, although there will still be online components. It'll be outside of Washington, DC next year. And I do think this is really an opportunity to get incredible science, but also to network with incredible scientists. And so encourage you to think about joining us next year, either online or in person in Washington. I'll also mention this, a small non-governmental organization that I had the privilege to found with some colleagues many years ago now, that works more on the human rights side of health. And so that's an important part, as I mentioned, and to pursue as well. More interest, or if you have more interest on the UK Public Health Rapid Support Team, a few places where you can look. And we do have an interest group and journal club, and it doesn't matter where in the world you are, you can tap into that, and we will keep you posted on our activities. And there are various presentations and things that you can get to online. And so feel free to join us. And a few suggestions of reading. I can share these slides with you for people who would like to come back to that. And I think that's my last slide. Ahmed, I'll stop there and take any questions if we have time. Thank you.
So thank you, Daniel, for this amazing lecture, where there is a few remarks here. So we need to start from the local community. This is a very important message here. Another important message is that, and you said this at start, you need to act locally, but think always globally. We need to identify the gap before starting, before having the problem itself. So all of these are important points. So we need to keep in mind during when we discuss outbreak situation and so on. So now it's open for question. If anybody, we still have 15 minutes. I'm really thankful for Daniel that he left long time for questions. You can use the chat option, please, to write the question you would like to have in mind for him. I can start until the heat here started. You said very important thing that it's not a response team, it's a support team. What really we miss nowadays in our world, that the initiative come from inside the country, not from outside the country?
Thanks for the question, Ahmed. You may want to put on my video again. I'm not sure, it's up to you, but looks
no,
like
I will put it, of course. Yes.
Looks like it's blocked from your side.
Yeah.
So yeah, I think that we're seeing that there is the expectation that national stakeholders are calling the shots, if you will, for outbreak response. And great, thank you. And I think that's, that's great. There, of course, still need to be, not all countries have the resources nor the technical capacity that they need for response. And so we need to work with them in order to shore up that technical capacity. But it's not me coming from London saying, here's what you should do. It's working with those partners who express their needs. And so we really try through our team to make sure that our program is sculpted in collaboration with partners. So for example, we work closely with Nigeria CDC is one of the countries. And so we don't say, okay, Nigeria CDC, here's what you should do. We say, okay, Nigeria CDC, what support can we offer? And we put together the program, not only for outbreak response, but also for the capacity development and the research. And so they've asked for support. For example, if you look, I'll use the example of Lassa fever as a hemorrhagic fever that is prevalent across West Africa, especially in Nigeria, a disease I've worked in for many years in places in West Africa. So we've been able to not only support Nigeria CDC during outbreaks of Lassa fever, but also conducting research on the lab side, looking at what often happens during outbreaks is that people who fit the case definition turn out not to have, of course, the target disease. So only about, in this instance in Nigeria, only about 25% of the suspected cases of Lassa fever turn out to have Lassa fever. And so one of the big questions has been, what are all the other things that are in there when someone presents with what could be Lassa fever and it's not, what might it be? And so we've been working with them in the laboratory to work up the negative samples to have a better understanding, finding some very interesting things in terms of pathogens and conditions that cause similar disease, but also then working on aspects related to healthcare seeking behavior. Where do people go when they might have a viral hemorrhagic fever? What are the signs and symptoms that prompt them to go? But also working with colleagues in Sierra Leone to establish capacity for clinical research. And so as you can see across that program, it's outbreak driven perhaps, but it also has very significant research and capacity development aspects that are not driven by us. It's not us saying, okay, here's what we need to do. It's colleagues in Nigeria and Sierra Leone saying this is what we need to do. So we welcome that. Of course, our resources are not infinite. We have to look into and see what we have, but nevertheless, that's our approach, is that we are partners on a journey, not the ones who dictate the direction of the journey.
Yeah. So we have a very nice question here from Martin Fay from Institut Pasteur, Dakar, Senegal. He's asking, what is the most challenging aspect for response preparedness? By the way, Martin, he was involved in the Congo outbreak. He was in the middle of the outbreak. Yeah.
Thank you, Martin. I think the most challenging aspect really is to make the local community a true partner. And if we don't do that, I think then we will, we always fail. And when we eventually do that, that's when we succeed. But it's not easily done, right? Because when you're coming from the outside, so you can imagine, no matter where you're tuning in from today, imagine that people from far away, and it doesn't necessarily need to be a foreign country. It can be just far away from another city in your country that is distant, but also has cultural and often linguistic differences. And imagine that those people all of a sudden come into wherever you live and say, here's this disease that you may never have heard of, that you need to change your behavior and change the way you do things. And so unfortunately, that is not an easy thing for any of us to accept, right? We wouldn't easily be able to accept that in London or Geneva or any of the other places. And so that's the challenge, to really come in early on in the outbreak in a very open way and make sure that we're all understanding the same threat. And one of the challenges there is that, we often are, understandably, but we need to find a way to get beyond the focus being only on the target disease. And so not because we're doing it intentionally, but one of the challenges, for example, is that we may be passing by the child who has malaria to find the child who has Ebola. But the child with malaria is still sick and may be dying. And so, that mother appropriately asked, why do you want to find this child who has this disease I've never heard of, or my kid is here, sick with this disease that we know has been a problem for us. So we need to try to break down the silos between outbreak response, which is very technically oriented for one disease, and a greater humanitarian response that has broader impact. And if we can do that, not only is it ethically the right thing to do, but strategically, then we get people on a local level who want to support us because they feel confident that we're really there for their best interests. So I think that, Martin, the answer is really of getting that local population on board to understand the threat as we understand the threat, and to be part of an equal part of our team.
Many thanks for referring of this. Because of that, we have today we have a very important presentation from Mitali, where he will speak what is the effect of COVID on other diseases, either in positive way or negative way. Because everybody, as you said, you always ignore the main problem during an outbreak situation. I have here an important question from Abdullah Sami. He said climate change has an effect on disease preparedness and outbreak investigation. So what's your comment on that?
No doubt that there are impacts of climate change, and climate change is of course looming behind. We're all focusing on COVID-19 as the big problem of our day, and indeed it is, and we need to get past it, and we will get past it. It's going to still take some time, but we will get control of COVID-19. But climate change, of course, is undoubtedly the biggest threat to our planet right now, and indeed in many ways, but also as you've correctly said, that when we see different pathogens, there are areas where climate change has an impact on either the pathogen itself or the host of a zoonotic pathogen. It's not always, we should be honest and say it's not always there are pathogens that may decrease transmission because of climate change, but there are many that may increase, where different habitats become hospitable to different sorts of animals that were not hospitable before. And so you can find that, and we're seeing in different areas where the extension of reservoirs into areas up the sides of mountains as time gets, as the temperatures get warmer. So we're seeing that climate change and habitat perturbation also has a huge impact, as we have a huge population explosion that continues on our planet, and that people going into aspects of our planet or areas of our planet and so as they burrow deeper for economic reasons into forests and mines and things, then they're in contact with animals, and we're seeing that that we have that impact of, for example, Marburg hemorrhagic fever that comes from contact with bats and mines, and also probably Ebola from forests. And so those sorts of interactions that climate change underlies really, and habitat perturbation underlies, will still really produce more and more, I think, events of pathogens that have the opportunity to come into humans. And when that pathogen happens to be something that is quite transmissible between humans, and then has the potential for severe human disease, which COVID-19 does, then of course we get into big problems. So it is something that we really need to be addressing.
Yeah, there is also another important question from Professor Thulz from Mansoura University, Egypt, where he is saying that how we can convince local community and big local leader, like religious leader, other stuff, of what we are doing locally to control disease, because this is, I think, a very difficult task.
Yeah. Indeed it is, and there's no easy way, but I think it's really just developing a relationship, right? And we can all intuitively understand that one develops a relationship, and if you develop a relationship that ultimately is based on trust, and so since I know you, Ahmed, and you know me, and so if you tell me something, and since we've developed that relationship, that trust, then I'll say, okay, then I believe you that here's this new disease that causes this symptom and is transmitted this way, and then so and you tell me what we need to do to try to prevent it. So developing that trust is extremely important. two elements that need to be mentioned of that, and I won't get into the specifics, I guess, but I did mention in my talk, the political leadership is incredibly important, right? And so we need to have transparent leadership that tells us that science is real, that this is not something that's made up. We have to respect science. It's confusing often for all of us. We know that one study doesn't necessarily tell us the answer all the time, and it can take time for us to figure out the scientific truth. But nevertheless, there is truth that is established and determined through science, and we need to respect that process, and we need globally leaders that respect that process, put the right scientists into leadership positions and to drive healthcare in the right directions and tell us the right thing. And then we have the problem, of course, of the infodemic and the misinformation, and that needs to start, controlling that, first of all, needs to start at the top, and to have really sound political leadership, as I mentioned, that is transparent about the science. And then we need to be able to understand what drives much of the rumors and the other things that undermine trust. But it's really about establishing trust. And so, that's not easy to do necessarily, and it's long term. But I think it starts with really developing that relationship, so that when the emergency happens, that people have already developed a degree of trust and then can act rapidly together.
So Daniel, was really amazing, as you mentioned. And last point, social media become a big headache, and the problem, I must admit, and I say it also for everybody in this meeting, that scientists start to distribute this false information, and we have a big problem. Not from the community, from the community itself, but scientists going forward and really distribute misinformation because they would like to have higher position or anything. And this is a big problem nowadays to control diseases.
Yeah, I think, unfortunately, that does happen. All we can do is to ask people to act responsibly, to understand really that you're in a position of leadership in the sciences across the world. We're very privileged in the sciences that people tend to listen to us and want to listen to us, and we have to be responsible as stewards of that privilege, and tell the truth and be honest about what we know and honest about what we don't know, and of course, we all have our scientific and professional ambitions. That's fine, but we need to have the limits on those to make sure that we're acting responsibly.
Yeah. So Daniel, we exactly having the 30 minutes. Many thanks for being with us. It was an honor to have you, and I hope to see you soon in person, not only the online version. So. And I advise everybody to attend the meeting next year.
Great. Thank you, Ahmed. Thank you, everyone. An honor to be with you.
Okay, many thanks.
Bye-bye.
Bye-bye.
Hello, hello, Dr. Ahmed. I can't hear anything.
Dr. Ghada, I'm hearing you. It's very good.
Okay, so
that's good.
I shared the screen. Shall I go on?
Yes, please enlarge the screen because you have it on the.
Okay, I'll do it.
That's good.
Okay, good morning, everybody. Thanks, Dr. Mohamed Shalaby, and thanks, Dr. Ahmed Abdelwahed, for inviting me. My presentation today is on the epidemiology of COVID-19 in Egypt. I'm going to give you an updated overview on the status and what are the, we will brainstorm together what would be the determinants or attributes for a potential for a second wave in Egypt. The topics that will be discussed in this presentation, as I mentioned, the epidemiological features of COVID-19, and I'm going to give you an overview about this epidemiological status in relation to the regional and global context, within the regional and global context. And then, as I mentioned, we are going to discuss a little bit the determinants of potential second wave in Egypt. So let's start with the current epidemiological features, and the WHO classifies the transmission of any infectious diseases into categories. And Egypt now is in the status or in the category of cluster of cases, meaning that the cases of COVID-19 are clustered either in time, geographical location, or by common exposure. And as you can see in the slide, there are several stages or several kinds of categories of transmission. We are in the stage of clusters of cases. This is the epidemiological curve of COVID-19 in Egypt since the inception of the epidemic. The first case in Egypt commenced or appeared on the 14th of February. And since then, there is a continuous growth in the number of cases, and the epidemic curve, as you can see, took the bell-shaped curve, and it reaches the highest number of cases, which are around 2,000 cases. And then there were a gradual drop in the number of cases. But as you can see, the number of cases did not drop to zero as expected, because there are still many susceptible individuals in the Egyptian population. And as you can see at the end of the curve, there is a slight upsurge in the number of cases starting from the mid-November. And this is, again, the first case appeared on the 14th, and this is a highlight of the pattern in the last month, over the last month of November. If we took a closer look on the last 14 days, or actually the last months from the beginning of November, you can see that at the beginning of this month, the number of reported cases were around 179 cases, and the last reported the last figure here in this graph was on the 18th of November, and it was with an increase of 100 cases. And if we look at the cases reported yesterday, it was around the double. The number of cases has doubled from the beginning of November to nearly the end of November, which rings a bell, which is an alarming sign that the epidemic is, or the growth rate of the epidemic starts to increase again. The number of deaths, again, it similarly took the same pattern as the number of cases, and it increased in the months of July and June and July, and then there is a decline, but again there is a kind of a steady pattern since August, and the decline and the number of deaths is around 20-25 as shown in this graph. If we look at the incidence, the cumulative incidence, which is the number of, it's the total number in this graph, I plotted the number of cases again since the start of the epidemic till the end of the epidemic over the population number, which is the population, the Egyptian population reported in January 1st, 2020. And as you can see, again, the cumulative incidence was very low at the beginning, and this makes sense because the number of cases were small at the beginning of the epidemic, and as the number of cases grows, the cumulative incidence increased, and the latest reported figure, as shown in this graph, was 108 per 100,000 population. So we have 108 cases for every 100,000 population. Another important parameter of any epidemic is to report on the epidemic growth rate, which is the rate at which the number of cases increase between time 1 and time 2. And here is the weekly growth rate in the epidemic in Egypt. And as you can see in this graph, the epidemic grows rapidly on March. In the first week of March, it reaches the highest level, 1.18. And then with the mitigation and adoption of mitigation measures, the growth rate declined dramatically with the partial curfew and suspension of education and prohibition of mass gathering. And as you can see, there are some sort of fluctuation in the growth rate, and actually the peaks or the increase in the growth rate in the graph corresponds with loosening of the mitigation measures, like loosening of the curfew, or when the lockdown is lifted, you can see the upsurge or the increase in the growth rate. The growth rate reaches a very low level, as you can see in the months of August, September, but it's again a very alarming sign that it starts to grow again, and it from 0 to 0.1. And if we didn't we didn't abide by the mitigation measures and precautionary measure, this might be another this might be a sign for the emergence of a second wave. This doubling time is another important parameter. Again, it indicates the transmissibility and the growth of the epidemic. And when the doubling time increases, means that the growth of the epidemic is slow, and if the epidemic doubling time is short, it means that the epidemic will grows rapidly. At the beginning of the epidemic, again, it was very the epidemic growth, the doubling time was very short, and then it increases. The latest figure, and unfortunately okay, now I can see the figures. It reaches the latest reported figure for the doubling time was 339 days. So this means the number of cases will double, or the epidemic will double in number every 400 days, compared to days and even a week in the early stages of the epidemic. The basic reproductive number is the number of cases infected, the number of each infected person on average, how many cases this infected person infects other people. Like, for example, in measles, the basic reproductive number is 15, which means that for each infected person with measles, he can infect on average 15 individuals. For COVID, it has been estimated to be 2 to 3 individuals, which means each COVID-19 infected person can transmit the infection to 2 to 3 persons on average. This is the basic reproductive number in Egypt, and it shows that, again, it was very high at the beginning of the epidemic, and then the latest reported figure is 1, which means that each individual person can transmit the infection to 1 person. The case fatality rate, which means that for the diagnosed cases with COVID-19, how many of those will die? It's an indication of the severity of the disease. The case fatality rate increases over the course of the epidemic, and it shows a decline again in June. But again, the case fatality rate currently is around 6%, which is higher than the figures reported in June. And all these indicators, as I mentioned, it's an alarming signs that the government and the society and the individuals and the community should be aware of, to take their precautionary measures to prevent the upsurge and the potential of a second wave in Egypt. So it's very crucial to have an overview, or to understand these parameters for transmission, and to understand the characters of the epidemic in order to adopt precautionary measures. And it's very important as well to have to put this in the context of the global and regional characteristics or situation. If we look at the global status, as you can see that in this map, that there are different color grades, and the darker the color, it means that we have a higher number of cases. This graph actually focuses on the number of cases in the last 7 days between the 9th of November and the 15th of November. And Egypt, luckily, is among the countries in the world that has a reasonably low number of cases. The cases, as you can see, the shade is a bit lighter, and it indicates that we have cases less than 100 case per 1 million population. In the region, in Africa, Egypt lies in the 3rd position in the number of cases, and it's preceded by South Africa and Morocco. I looked actually for an updated publications on the epidemiology of COVID-19 in the world to compare our parameters with the global and regional figures, and I was unsuccessful actually to find unupdated figures or current figures regarding the doubling time and our note in different countries and in the world, maybe because I was really short in time, but I found some figures in Scotland and England, and they were actually corresponding to the figures in Egypt, the R note, which are the average number of infected individuals by an infected person. And the range was around between 0.08, which is less than 1, which means that for each infected, one infected person will infect less than 1. And this is an indication that the epidemic will die out and there will be no growth. This was reported in Scotland, and in England it reaches between 1.2 and 1.4, which is above the range above 1, which is the figure that all countries want to achieve, and even below 1 to end the epidemic. The doubling time I found in a study that was published in US, and it indicates that the doubling time is very sensitive to mitigation measures and containment measures. The doubling time was reported in United States was reported to be around 3 days before the mitigation measures, and increased to 15 days as the mitigation measures were adopted. And interestingly, that they compared the countries with stay-at-home orders and countries without stay-at-home orders, and again, the doubling time was significantly different. It reaches around 400 days in countries that have stay-at-home orders. If we move to the third part of the presentation, which is the determinants of the potential for second wave in Egypt. Sorry?
You have 5 minutes left.
Okay, it's about the same time for the rest of the presentation. The potential for second wave in Egypt, it's based on the prevalence of infection, and which relies heavily on the testing rate, the health system capacity and resilience, the ability of the system to adapt to crisis and to accommodate for increased number of cases, COVID-19 immunity, how long it lasts and how much protection it offers, mitigation measures, how much they are enforced and how much the population is complying with these measures, and progress in preventive and curative measures. I'm going to give you just a bit of some of the data that I gathered on the testing rate. I just want to show you that we don't have data, published data on the testing rate in Egypt, and the reported data shows that the testing rate is very low. So we don't have a clear picture of how much people are infected with COVID-19 in Egypt. The actual number is lacking. This is number one. Number two, health system capacity. We have the data that shows again that our health system is far beyond the levels or the standards that should be available, or the benchmarks that should be available to respond to any crisis. If we see the number of beds in Egypt, it's 13 per 10,000 population, and if we compare this to countries all over the world, it's very low. And again, the number of doctors and the number of nurses and midwives are very, very low regarding the benchmarks, the recommended benchmarks. Again, the number of inpatients, ventilators, and CT scan are very low. That needs to, and the countries need to adopt innovative measures in order to address such gaps. And one of the innovative solutions could be engaging the private sectors in the provision of healthcare. Immunity, and I leave this to the experts, we still have unsolved question regarding the quality, duration of the immunity, how long the immunity lasts, and of course this is a gap in research that should be addressed to follow up infected individuals and resolved individuals from COVID-19 to see how much or how long the immunity lasts. Mitigation measures in Egypt. This is a list of mitigation measures that has been or have been conducted in Egypt. And I would like to end with this slide. And I actually raised some questions, and I would like the experts in this meeting, they might address these questions in their next presentations, and also the participants, they might have clues for these questions. When the vaccine is fully available, and if the vaccine would be given to all the population or just susceptible or at-risk groups, the vaccine progress and the handling, would this affect the coverage and the administration effectiveness of the vaccine? How long it offers protection for those who are administered the vaccine? And does the vaccine affect the pathogenicity or only, infectivity only, or both? Meaning that if I give the vaccine to an individual, does it prevent the development of disease only, or does eliminate the virus so that the person does not develop the disease and does not transmit the disease as well to the community? And thank you for your attention.
So many thanks, Prof. Ghada, for this nice presentation. And an overview about the situation in Egypt, which is, I think, one of the complete presentation. You have mentioned very important gaps here, testing gap, and this is what also Professor Osama Youssef from Cairo University, Egypt, has mentioned, that we have a low percent of going undiagnosed in Egypt. The immunity gap, how much the immunity coverage is also an important stuff which describe the situation. There is a very important question from Ala Al-Khouli from Egypt, from the Vaccine and Serum Research Institute, where he said that, what about the animal part of the story? Because there is reports from other countries that dogs, cats, and wild animal can transmit infection. And the question is that, what's your opinion about that? Is the Ministry of Health, I think, need to collaborate with the Ministry of Agriculture and do something on this issue? Ghada, you are hearing us?
Yes, I'm sorry, I have some technical issues. I'm sorry, would you please repeat the question again?
So I was trying that, what about the animal source in the story?
There has been, in the epidemiology of COVID-19, as with SARS and MERS-CoV, previous epidemics, these epidemics are claimed to be zoonotic in origin. And this is very important that also the WHO announced before that most of the upcoming epidemics and pandemics, global pandemics, will be originated from animals. And this is very important issue because unless we identify the reservoir or the source of infection, we wouldn't be able to control any epidemic or new emerging diseases. For the COVID-19, several animal sources has been claimed to be the reservoir of infection, like bats, snakes, pangolins, and but up to my knowledge, the specific animal source has been confirmed as yet. I think it's the research is still ongoing, and we're still lacking a lot of information regarding COVID-19. I raised some in my presentation, and there are many other research gaps that we need to address in our research agenda, whether at the national level or at the global level.
Thanks, Dr. Ghada. To keep on time, I will move to Dr. Mohamed Munir, but Dr. Ghada, please stay with us. We have in 30 minutes a general discussion part where I'm sure that there are many people have a question in mind, because you will be like the responsible for the situation in the whole Egypt in the coming minutes. So now I would like to welcome our next speaker, Professor Dr. Mohamed Munir from Lancaster University, UK. We are happy to have him because vaccination is an important topic nowadays, because we have almost 3 vaccines which we have results. And I'm aware that Professor Munir himself, he is busy for having also a vaccine. So I'm sure that we will hear a very interesting lecture from an expert of vaccine. So Mohamed, the mic is yours, and we are happy having you with us.
Ahmed, can you hear me?
Yes, I'm hearing you. I'm hearing you. I'm seeing you.
Oh, perfect. Can you see the slides up for everybody?
Yes, everybody seeing your slides. It's perfectly done. Many thanks.
Perfect. Thank you. Thank you very much, Ahmed, once again. And I would like to thank the organizers, Professor Shalaby, who've been very kind inviting me to come in for this lecture. So all I will be doing is really to take you through some of the current advances in vaccines and what are the challenges. Do we really need to be very hopeful, or there are some disappointment? So it would be pretty interactive, where I wanted to really give you a flavor of what is the reality and the underworld ongoing with in terms of vaccines. So just let me set my stopwatch so that I don't run out of the time. Otherwise, it would be all good. Right. So I think for these audience, I know most of them either are involved within the SARS-2 research or involved with other aspects of the viruses. Don't need to convince them that vaccines are really powerful to keep the diseases at bay. Because without vaccines, we have had so many disease emergence, not only in the developing world, but also in the developed world. And over the years and over the history, we have established a very strong portfolio about the successful vaccines. And some of those are listed here onto the left side of that. And then one of the things that I think probably everybody of us come across is MMR vaccine, although there are a few links about the impact of MMR onto other neurological issues. Those are debunked and devalued already, but this is one of the success story. I think nobody can deny that. But the thing that I want you to little focus on here is that while we have a list of diseases and the list of the vaccines available, not every vaccine has been a success. But some of the vaccines, for example, mentioned here, for example, if we talk about tetanus, Ebola, MMR, polio, smallpox, chickenpox, measles, these are really a great success vaccines. With a high level of protection. For example, if we talk about tetanus, Ebola, those being like 100% protection. And now what we are talking about is COVID-19, which isn't really getting too far from that. So compared to, for example, Rota and the flu, the vaccine successes with other diseases has been enormous. So all I want you to really recall is the value and the importance of vaccine. And I think this pandemic has made everybody realize really hard that vaccines are really the ultimate tool to sort of curtail the impact of this deadly pandemic. But before I take into what is currently ongoing, I just want to give you a flavor like how the vaccines are developed, because that is one of the fundamental questions people are always asking, like why vaccines are taking so long time. So here is basically a timeline that is influenced by politics, it's influenced by bureaucracy, and there are some organizational challenges as well that make the whole pipeline for a vaccine production up to 15 years, which is significantly and a massive amount of time. But if we really break that time into small chunks. Major part, I think, goes for the technology development and research and the design, how to develop the vaccine. And because each virus is different of in its own, therefore, a certain technological optimization is required. So therefore, most of the time go on to the technological development. And then 2 to 3 or 4 years go on to preclinical study where you do pharmacology, toxicology in animal, in non-human primates. And once everything is proven, then it go into the clinical where go phase 1, phase 2, and phase 3 stages. In the phase 1, you look onto side effects, dosage regime. Phase 2, you expand on to further optimization toward the immunological responses. And in phase 3, you look for the protection. Once those phases are completed, then the documents are submitted to the regulatory body, for example, Food and Drug Administration, European Medicine Agency, or here in Medical and Healthcare Regulatory Agency in the UK. So once those are approved, then the real challenge come into production and distribution, because until we don't really have the distribution of the vaccine up to the scale where it need to be, it's probably meaningless to have a vaccine. But now the thing that I want you to get emphasis on is like 15 years is now sequestered into only a year, which is really something that I will be taking a lot of time to talk about. So having said that, there are challenges. Even if we would have the vaccine, there are a lot of challenges that need to be tackled before really we start seeing the impact of this vaccine onto the global scale. First is the production at scale. I mean, we're talking about billions of doses. We need at least 11 billion doses of COVID-19 vaccine to immunize 70% of the world population, which is really a big ask. And what we are talking about is, for example, vaccines about Moderna and Pfizer's. They've never been into that big businesses before. And at the moment, there is no licensed vaccine, but most of the technologies, those running up in the front, they are relatively new technologies. But once that is production is on the scale, then we got to do a distribution at scale. And this is one of the biggest ask I will always say is that, for instance, we have measles vaccine, very effective vaccine, 90 to 95% protection, but it is not going into every corner of the world. Therefore, disease is still prevalent. The same is the case with the polio. So distribution is really the key. And then is the administration, because getting into a country is one thing, but getting into the arm of somebody is another thing. And then last but not the least is that we still have so many answers to be explored. For example, how long the immunity lasts, whether the vaccine protect against the disease itself or not, or it spread from the transmission. The transmission can also be stopped or not through all of these vaccine regimes. Those are being proposed. So certainly there are a lot of challenges. And on the top of it, there are administrative, cultural, and financial complications, depending on the country we speak to. So even we have the vaccine, still challenges are not finished. There will be a lot more need to be explored. But one thing that became very powerful this time is that the vaccine research has gone to the scale that we never seen in the living history before. For example, if we talk about now, we have over 236 vaccines, and basically around 62, 63 vaccines are in the human trials and the clinical trial, which is enormous within a year. And now we have around 12 vaccines. Those are in the phase 3, which is a last stage trial before a vaccine could be approved. There are vaccines, those are approved for emergency use, for example, Sinovac from the Chinese, but there isn't anyone that is approved at the scale to be immunized into general population. Right, so that was just a little bit background, but one thing I would like to you to understand really is that what is the basis for the vaccines that we are currently deploying and currently are working at the scale that need to be. Here is the schematic diagram of SARS-2. And one of the protein that is decorating the virus onto the surface is the spike protein. And this spike protein is the most critical protein when it comes to vaccine, when it comes to host tropism, and when it comes to immunity. And one of the primary reason is that this is the protein that, so this is plasma membrane, the cell one, and the viral membrane. And here is the spike protein, and this is the ACE2 receptor onto the cell. So the interaction between the ACE2 and SARS-2 is critical to initiate the infection cycle of the virus. And if we can break this cycle by interfering with this interaction, that means we will let the virus not to infect the human population. And if that is the case, we will be protecting, and that is really the basis for the vaccine. So here is the crystal structure of the spike protein. I mean, within 2 months, people have managed to do the crystal structure of the full-length spike protein, which was incredible and gave us quite strong sort of grounding to develop vaccine based on the most stable expression of the spike protein. So here is on the topmost surface that is required, the receptor binding domain on the top, and this make really the center for the neutralizing antibodies, because if we have the neutralizing antibodies around this domain, basically what we are doing is to sort of interfere with this interaction. Having said that, using this spike protein, which is an integral component of the virus and essential part of the vaccines, different vaccines have been proposed that include from the vectored vaccines to attenuated vaccines, inactivated vaccine, messenger RNA subunit vaccine. And all of these vaccines have its own merits and demerits. Okay, so you can't really superiorize any vaccine than other depending on how it is administered, how it is scaled up, and how it is going through with phase 3, particularly against the protection, the level of antibody they will induce. So in next 10-15 minutes, I will take you through some of the front runner vaccines, the data they have in terms of neutralizing antibodies, in terms of T cell responses, because until we don't really understand that, it would be very difficult to sort of categorize and prioritize the vaccine regimes. But this is something very interesting this time happened. I mean, we just to put into the perspective, we have around 8 pandemics in last 20 years, but we never seen such a diversity of the vaccine platform coming forward. So if we look onto the different vaccines, for example, vectored mRNA, DNA-based vaccine, or subunit vaccines, or inactivated even, those have been enormous and are very well represented in across all of the phase trial, particularly in phase 3 trial. And just because of the unprecedented need, I think it was calculated that if the vaccine demonstrates 60% efficacy against the natural course of infection, this would make a significant contribution to this pandemic. And that means that only 150 people need to be infected into phase 3 trial, which is probably the minimum number that has been set for any vaccines to be trialed. But all I wanted you to think about is that the vaccines, those are in phase 3 trial, they are representing a diverse range of technologies, probably for the first time in the history, which is really a good news in a way, because if one vaccine approach failed, that means that we have a second technology to back it up. So here is just the snapshot of our current vaccines platforms. For example, the vectored vaccines are being produced by, the Sputnik 5, the Russian one, or the CanSino, AstraZeneca, Johnson & Johnson. All these are around the vectored vaccine approach. And then we have the DNA-based vaccine. Those are relatively behind the curve, but still, for example, Sanofi or Inovio, they are approaching to phase 2 at the end of the phase 2, starting phase 3 soon. And then we have mRNA-based vaccine, such as Moderna and Pfizer. I think everybody knows about that, and we will go into small detail in a minute as well. And then we have subunit vaccines such as Novavax. Novavax is the third vaccine here in the UK that is starting the phase 3 trial. And then we have inactivated vaccine or live attenuated vaccine. So there's relatively smaller number of live attenuated vaccine because of the risk of reemergence of the infection if the attenuation reverts, particularly for such a medically important infection. So through this slide, I want you to emphasize on 2 of the things, is the antibody responses and T cell responses. Why is that? Because we have to really identify what are really the correlates of protection. Because until we don't really know what are really protecting the person from natural course of infection when somebody is immunized, it's really hard to assess the efficacy of the vaccine. So when the SARS itself passed through nasal or oral cavity, it in fact, the upper respiratory tract go back into the lung, really at the deeper region, and start to replicate. And when it replicates, it enters through the ACE2 receptor, and within the cytoplasm, it completes all steps required for transcription and translation. And once the proteins of the virus and the genetic material is replicated, then it is released. And when virus is released from an infected cells, these are now encountered by antigen presenting cells, such as macrophages, for example. So once these macrophages are sensing these viruses, those are circulating into the body, the T helper cells have to play a role, because T helper cell will then develop cytotoxic T cells or prime the B cells. So these two are critically important for vaccine efficacy when it comes to coronaviruses. For example, B cells have to tame and produce the monoclonal antibodies against the SARS-2, and then the T cell itself has to act onto the virus infected cells, for example, this one, to really remove from the body. So if any vaccine produces the T cell responses as well as antibody responses, I think these are really critical for the success of the vaccine. And that is based on data that has been generated for many of the diseases. For example, here is the list of the success stories for the vaccines, those being deployed in the field before in the history of human vaccinology. And people have identified how much antibody responses, for example, is required, determined by a specific test that can guarantee that this person would be protected. When it comes to SARS-2, we don't really exactly know how much level of antibodies are required to really correlate for the protection. But what is certain is that the antibody responses would be critical to neutralize the virus and to mount a profound protection. And this protection has been based on the non-human primate studies being done in relatively early stages. For example, we knew that in rhesus macaque, if they are infected once, they will induce a strong level of antibodies. And if you reinfect them, there wouldn't be any replication of the virus. So here is the primary after primary infection, and here is after secondary infection. So very little infection has been noticed in rhesus macaque if they are reinfected. So this means that those non-human primates would have the antibody responses, and those antibody responses protect them against the reinfection. Another response that was very important to understand, that neutralizing antibodies in vaccinated non-human primate really strongly correlated with the protection. For example, this if you take the bronchoalveolar lavage and look for the antibody titers versus the RNA copy. So as the titer increases, the RNA copy decreases. So this is a strong correlation in the BAL, bronchoalveolar lavage. However, that correlation wasn't really common in the nasal swab. So this means that the neutralizing antibody at a particular location is critical for the success of any vaccine. So taking message from there, I think one thing is important that I would like to raise a question here is that what kind of immunity are we expecting from a vaccine? Do we expect that it would protect us from getting infection, or we are expecting that it would protect us from getting a disease or a severe form of the disease, or we would be able to block the transmission of the infection, or the immunity will be long lasting? So these are the questions that are still need to be addressed, and we don't have yet information. We do have some information that, for example, Pfizer and Moderna vaccines, those can protect against severe disease, but we don't really know whether they can protect the vaccinated person from shedding the infection. So thus, would that have impact on to the transmission or not? But one thing is very important, that most of the antibodies that are required for neutralization against the SARS-2 are the secretory IgA that are in the upper respiratory tract, or IgG, particularly IgG1, those are into the lung. Those are the two critical antibodies subtypes that are critical for SARS-2 neutralization. So now let me quickly run you through for the 3 or 4 vaccines. Those are currently in a hotline, what their data is and what they really are claiming. So as I mentioned, I think it is pretty clear that the neutralizing antibody responses and T cell responses are critical for the success of a vaccine. So if we talk about CanSino Bio vaccine, which is based on adenovirus 5 vector, it's a vectored vaccine. It is currently in phase 3. They use a heavy dose of the virus, as you can see, 5 in 10 to 10. And it is a good thing is that it's a single shot, it's given intramuscularly, and they have tested in around 500 people for the phase 1 and phase 2 trial combined. So as you can see, So on 14 days, there's a relatively little response, but after 28 days, a massive level of antibody responses was compared to the placebo control group. So antibody has been critical, and that correlated quite well with the T cell responses. So if you measure the interferon gamma expressing cells into the bone marrow derived dendritic cells, you will be able to identify the level of T cell responses induced. So this really hit the mark that neutralizing antibody and T cells are important. That's why they went into phase 3 trial. And then the Oxford AstraZeneca, it didn't really perform very well into non-human primates because it didn't really stop the shedding. It didn't really induce the strong neutralizing antibodies. But they also used a massive quantity of the virus as well. And it was, instead of having one dose, this was 2 doses with 28 days apart, again, intramuscular with around 1,000 people recruited from 18 to 55 years old. Some level of antibody responses were produced compared to meningococcal placebo control, because one of the challenge they had is that the adenovirus vaccine itself, if you inject into the arm, it induces some sort of side effects anyways. So the randomized trial condition is such that people wouldn't be understanding that they are either in the control group or in the vaccinated group. So therefore, they have to give a vaccine, the meningococcal vaccine, because it induces the same level of pain, same level of reaction. So people wouldn't identify whether they are injected with the COVID-19 vaccine or with the meningococcal vaccine. But they do see the T cell responses, because that is particularly important when it comes to adenoviruses, because adenoviruses are relatively critical when it comes to the T cell responses. So again, this hit some mark, but it wasn't really success in the non-human primate and phase 1 and phase 2 trial. But certainly they did induce the neutralizing antibody and T cell responses. The second last is the Moderna vaccine. Again, new technology, mRNA-based vaccine, robust neutralizing antibody responses depending on the dose that you use, and they use different doses. For example, 25 microgram, 100 and 250 microgram. And for example, talking about 250 is a massive dose to give, and particularly when you are giving in 2 doses going into intramuscular. One thing they did is that they combined phase 1 and phase 2. They called phase 1 and phase 2, but they did only very small number of people from 18 to 55. And this is not really the vulnerable group anyways, because it's usually 60s. These are the ones that are in vulnerable group. But nonetheless, it has induced the antibody responses in phase 1 and phase 2 trial combined. The last bit is about the Pfizer and BioNTech vaccines. Again, the same technology as the Moderna one, but they use a different carrier in terms of adjuvant, in terms of boosting the immune responses. And therefore, they use relatively smaller quantity of the mRNA, 10, 30, and 100 microgram compared to 2500 and 250 in Moderna. The regime was the same, 2 doses, but just 21 days instead of 20 days, 28 days apart. In Moderna case, intramuscular, and again, small number, again, in the same group as that of Moderna. But it did induce neutralizing antibody more than the Moderna one, particularly when they were administered with a dose of 30 microgram, because that is the dose that they used in phase 3 trial, the one that became now 95% effective.
5 minutes.
So, yeah, so here is just the recap of the trial they have conducted and the way the whole vaccine regime is moving on. But just to put into the perspective, I just wanted to compare these 3 vaccines or 4 vaccines, including Sputnik, that are now in the front runner. Moderna, 95% efficacy with 2 doses. The same is the case with BioNTech and Pfizer, but they are different with the storage and transportation condition. For example, Moderna required -20 Celsius, which isn't really a problem at the small surgeries and the pharmacies, but -70 is really a big challenge. And here, AstraZeneca got a big advantage that can be stored at at 4 to 8 Celsius. The fridge temperature people can keep at the home as well. So just to, the final bit is really, I want to put a slide here, is that If we are using 2 doses regime, basically we are talking about 16 billion doses to immunize the whole world of 8 billion population. But even if you make a conservative calculation of 70% population immunization, we are still talking about 11 billion doses, and none of the vaccine is at the scale to be produced at 11 billion doses. Therefore, there are a lot of challenges, as I outlined here, need to be tackled before we start seeing the impact of this infection. And one of the problem I quickly want you to think about is, because Egypt is the same scale as that of other low and middle income countries, that most of the capacity that is being proposed by these front runner vaccines have already been taken up by the wealthy nations. And that is really critical, because if we don't have access to the low and middle income countries, this is going to be a problem. Just putting into the perspective, UK population is 70 million people. 67 to 70 million people, and they have already pledged 355 million doses, and that equate to 177 million. So they didn't need that. I mean, they made a contract with every possible front runner to really pledge so much that beyond like 10 times more than their population. And that is one of the major challenges that is being faced by the World Health Organization, by Gavi and SAPI, and therefore they have launched a program called COVAX, where low and middle income countries can contribute, and they will, initially they thought that they will be providing them with the 20% of their need, but now they said that they can only provide 3% of their need, with around 2 to 4 billion doses going into low and middle income countries free of cost. The thing that I would like to, the last bit is about the future of these vaccines. The first question I always been asked whether these are safe. I would say yes, these are safe because they've been tested on a larger cohort. And we don't know how long the vaccine would work because we didn't have that much information given the time. Do we have the sufficient quantity of the vaccines? No, it isn't. However, SAPI, along with COVAX facility, they are working very hard to make it available. Do we have access and equity? No, we don't have. We never have equitable distribution of the vaccines, neither for any other disease nor for COVID-19, and that put a great pressure for the developing countries to think about making their own infrastructure. And the last but not the least is that I would like to thank my group, particularly Dr. Mohamed Rahim, who has been very phenomenal in doing work on our COVID-19 vaccine and diagnostics, Professor Al-Nathur, and PhD student Mahmoud, Munir, Emily, and Juliana. My lab is funded by UK organizations such as Royal Society, Newton Fund, BBSRC, British Council, and some of the private sector. And with this note, I will be very happy to take questions as in the next session. Thank you.
So many thanks for this amazing presentation, which teach us a lot about vaccination. We forget it in the last, because we take vaccination for granted, I must admit, but now this outbreak has taught us that it's a lot of effort, and the pioneer people, they have done a lot of work in order that many diseases like pox virus and polio virus, it's now part of history, and we hope that with vaccine we can have also coronavirus as a part of history. We will see. So I would like to ask Dr. Ghada to join us for this session. So Dr. Ghada, can you open your camera? I will ask Dr. Munir.
Yes, I'm here.
Sharing, please, so we can have all the cameras on. So, Dr. Munir, can you stop sharing, please, your screen? Yes.
I am trying to find the way how to do it. Okay.
Yeah, I know. This is it will be above there in the middle of the screen on the top.
Right. Is it stopped now?
No, it didn't stop, but maybe because of the connection, it will stop. But you can just. I can also make the. So let me. Yes, now everything is good. So
perfect.
Yeah. So now, Dr. Ghada, so you please join us, and then in this discussion is very important. I will also both Professor Shalaby also on the spotlight that he will be with us, and also Dr. Ghada, please join us here in this discussion, because this is very important now in order to discuss a lot about what we have discussed so far. I will ask everybody has a question. Please use the chat option in order to go with us with this one. So there is a question about vaccination from Mohamed Farad. Is it possible to have a vaccine that's fully protect against the current and muted strain?
Yeah, it is possible, but unfortunately, we don't have such vaccines. First, because we don't have information if this virus mutates into something that is not neutralized by the immune responses induced by the current vaccines. But the vaccines, those are currently available, those are being tested in different parts of the world. For example, AstraZeneca vaccine is being tested in phase 3 trial in 6 or 7 different countries. For example, South Africa, Brazil, India, USA, UK. So all these countries are having a different genetic population, genetic background, and probably different circulation of the viruses, at least at the subspecies level. So my anticipation is that with the current rate of mutation of the virus, all the vaccines, those are being trialed in phase 3 would be protective enough. But if anything changed drastically in the future, for example, the mink virus, that the mink coronavirus mutated virus, if that drastically changes, that is something that WHO is looking very closely to look into any possible emergent and escape mutant, and that would be revising the vaccine strategy accordingly.
Okay, that's good. So we have from Ala Al-Kholi, he is directly working the Serum and Vaccine Institute. We had an interesting question. He said he is thinking more in the structure, and he said that the main part of binding to receptor is always hiding all the time from the virus. How we are sure to prevent the virus entry while we are targeting something is hidden in the virus itself?
Yeah, I think that's a very important question, actually, because that is the reason the vaccines, those are relatively successful. And in the front runner, they are taking the whole spike protein instead of using only the receptor binding domain. There is only one vaccine using the receptor binding domain went into phase 1 trial last week from America in India. But beside that one, all the vaccines, they are using the full length spike protein. So the neutralizing antibody that are not directly binding to the receptor binding domain still would be okay, because they can bind on to other sites within the spike protein and make the structure in such a way that it allow the virus not to enter into the cell. So antibodies against receptor binding domain are critical, but these are not the final bits that are required for immunization. So therefore, the whole spike protein is critical for immunization.
Okay, so we have another to Dr. Ghada now. We have an important question: is that if there is any confirmed case in Egypt with foodborne transmission of COVID-19, because it's nowadays you have many people have identified the virus in food package, but they are aware of cases as a from food source?
Not as yet. I think it's not even in any part of the world. The WHO confirms the main mode of transmission of the virus is through a respiratory route or respiratory droplets, either through direct inhalation or through contamination of surfaces, and touching such surfaces with contaminated droplets and touching the eyes, nose, and mouth. This is the confirmed route of transmission, although the virus is excreted in stool in cases. However, a fecal-oral mode of transmission is not confirmed yet.
So many thanks for your answer. I advise everybody to use the chat option in order to ask their question about the epidemiology in Egypt or about the vaccination. So there is a question from also Dr. Ala Al-Kholi. He is very interested, I think, in vaccination. So there are some nano-adjuvant that could possibly be used in COVID-19 vaccination, and an idea about last vaccine approved for clinical phase.
Yeah, I mean, adjuvants are really fertile area of research, and I don't think any of the inactivated vaccines or the mRNA vaccine wouldn't work without the nanoadjuvants. So certainly this is being looked very carefully, and also for the subunit vaccines, killed vaccines, adjuvants are critical. So without that, I don't really think that any vaccine would be mounting strong immune responses. an idea about last vaccines approved for clinical phase. Do you mean that would they be using the adjuvant if they would be approved by the phase 3 trial?
Dr. Ala,
Second,
please use the chat,
second part.
please. Yes. So, until Tala answer this, what I would like to ask you is that now what is the chances or what is the possibilities of Egypt to really increase the number of tests per day in order to cover more let's say asymptomatic cases, which as we know now that they are the driving force of the outbreak or the second wave, especially I must admit here in Germany, the driving force is the asymptomatic, not the symptomatic one, because if it's symptomatic, everybody know that now it stay at home. But now what is the strategy you think that we can do in Egypt in order to improve the diagnostic for asymptomatic patients?
I think testing is very crucial because, as you mentioned, the majority of cases are asymptomatic. So in order to identify the burden of infection, how many people are infected in any country. And in epidemiology, we hope to reach what we call herd immunity threshold, which is the proportion of the population which are immune against a particular infection. When we reach such level, it holds the transmission of infection. So the protected people or the immune people blocks the chain of transmission, so the disease does not progress and spread in a particular country. In Egypt, actually, we lack such information because the testing is first, it was confined to the Ministry of Health and Population Laboratories, and it was also confined to the people who are symptomatic. So if the person has symptoms, he seeks medical care and get the diagnosis, get the test, the PCR done, and is recorded at the files or the records of the Ministry of Health. Since September, the 1st of September, the Ministry of Health opens the doors for private laboratories to conduct the test. However, there is no formal statistics released regarding the number of tests done at the national level. So we don't know how many people are tested. We don't know how many people got the infection. This is number one. Number two, again, I'm raising the same questions. We don't know if the people who got the infection get immunity that lasts for long periods. So putting this in mind and putting the possibility that the person might get the infection again, we won't be able to reach the level of the herd immunity threshold, because the herd immunity threshold to be reached, it needs the disease to have a long-lasting immunity, long-lasting protection, so that the number of immune people blocks the transmission. So one way is to improve the testing and the surveillance and the recording of the number of tests done nationally. This is number one, to have a network of surveillance that connects the private sector, the university hospitals, and the Ministry of Health hospitals, and have a national figure. The second is to promote the research that identifies how long the immunity lasts. So if we have such information, we can determine the transmissibility and the progression of the pandemic, and if we are going to be protected or not.
So Dr. Munir, I will come to you now and ask you about the herd immunity, because it was a lot of discussion for this part from the UK government and in the UK. So I think it's a nasty question. So I would like to ask you more about what's your thought about herd immunity here, because this is, we heard a lot this word.
Yeah, that's true. I mean, as Ghada was mentioning, herd immunity is not really something that we should expect for many reasons. Let me put into the perspective, the measles virus is really, highly immunogenic, and it provides the sterilizing immunity. If somebody is infected once with the measles virus, they will be protected for the rest of their life. But we never achieved the herd immunity against measles. And we wouldn't be able to attain the herd immunity against SARS-2. And it's such a nasty thought and unethical procedure to follow, because that means that we will be losing hundreds and thousands of lives, and yet we won't be able to protect the young population, because still long COVID is one of the things that is critical. So if you allow the virus getting into the population, long COVID would be a problem for the long-term future. And I think that the living example against the herd immunity is the Sweden. So Sweden started this thought, and just last week they gave up, because the mortalities, the deaths in Sweden is 10 times more than the Norway. Norway is a very comparable, similar kind of culture in the Scandinavia. So, and now they decided to put a restriction onto the number of gathering. They started to put restriction onto the movements and so on, because they think the herd immunity cannot be achieved. And based on, I mean, we didn't have a vaccine against coronavirus in human, but based on our animal studies, we do know that the vaccine isn't effective against animal coronaviruses more than a year anyways. I mean, if we talk about all of the coronaviruses we are referring to, like IBV, and so they are very short-lived. So we should not expect that the antibody responses or the immunity induced by coronavirus vaccine would last longer than a year. And that has been proven before with the SARS and MERS. People who were infected in the beginning, they quickly diminished their antibodies after a year, though they were able to detect after 2 years or so. But even if you have the immunity after 2 years, meaning that you got to restart the herd immunity cycle, which would cost thousands and millions of lives. So all in all, I think the bottom line is that this is something that we should not aim through natural course of infection. That should be achieved through the vaccination.
Yeah, and there is a very important question here, that because there are many reports that the antibody response to coronavirus is very, there is a few studies which show that it can extend for a few months. So the question from Professor Mona Muhyiddin is that how we can say that the vaccine is long-term function if we don't know anything about how long the immunity lasts.
Yeah, absolutely. I mean, that is something we don't know the answer for at the moment, because at the phase 2, basically, even if we talk about phase 1 and phase 2 trial, that has only 4 or 5 months history. So the antibodies are depleting quite quickly because they have a very short half-lives. We do have some memory and the priming, but that isn't at the scale to protect against the infection. So that is something that we have to look and watch for coming months on this phase 3 trial. And that is the reason that FDA and WHO are very concerned that all the vaccine trials, although the vaccine probably would be approved by the end of this year, but all the trials need to be watched for next 12 months to see whether there is any side effect, or to see if the immunity induced by the vaccine is still protective enough against the infection or not. And it's not something that nobody is watching. We at the WHO are very careful, and we are looking into the mutant, as somebody asked the question before. We look at any possible mutant, would that be cross-reactive with the antibody induced by the vaccine or not? But again, the bottom line is that we don't know exactly for how long the antibody responses would last by the vaccine. It's just the time will tell.
So there is a very important question from Dr. Ghadir from Saudi Arabia, which we are happy that we have also a lot of colleagues from Saudi Arabia joining us in this meeting. So she asked a very important question. What do you think, how long it will take to cover 70% of a population in a country as a vaccination?
For a specific country or the whole world?
I think you can take it as an example for UK and then to the whole world. Yes.
Yeah, for UK is not a problem at all, because as you remember, I put a slide on just to emphasize onto this fact that our population is 70 million and we have a contract for 355 million doses. So the government claim is that if the vaccine would become available in December, by April, 70% of the population in the UK will be immunized. And they are thinking making it compulsory. But that is not really the problem. I mean, I exclude Europe, I exclude America out of this question. The real challenge is low and middle income countries. Countries like Pakistan, Egypt, and part in the Africa and Southeast Asia. I don't see that the 70% of population in low middle income countries would be fully immunized by the 2024. So just to put into the perspective, the COVAX and the Gavi, SAPI, and WHO, they made a facility for supporting the low and middle income countries. They only can promise now 3% of the population can get the vaccine in the low and middle income countries by the end of 2021. It's very important. Just want to emphasize, 3% population of Egypt will get vaccines from a COVAX facility by the end of 2021. So you can assume that still you're talking about 97% of the population. And that I don't really see happening in 2 or 3 years until we have a vaccine in surplus that could be used for those countries. Although there would be a philanthropist and very sympathetic approaches. For example, Canada is the one that have pledged the most doses, I think maybe 1 billion doses or so. And they said that any vaccine that would be in surplus would be given to low and middle income countries. So until those things are not coming, I can't see you and me, we will be immunized in our countries for that quickly.
Yes. So I will end this session with a very important question with Professor Shalaby, who is a member of the Ministry of Higher Education Committee, and he was stressing for years now why in Egypt we don't have our own CDC. I'm sure that Professor Ademovo George from Nigeria, he's hearing us. They have a very good experience with establishing their own Nigerian CDC, which is very good in controlling disease and having the data available for the community and everything. And I think, Prof. Shalaby, you need to comment on that, because I think it's an important point for Egypt about what we can do to have all the effort from the science, from the very good research institution in Egypt, the Ministry of Health, Ministry of Agriculture, Ministry of Higher Education, to come together in what's called CDC. And I'm sure that you have reached the higher position in the pyramid about this, and you need to comment on that. You need to unmute, Prof. Shalaby. You need to unmute. So down to the.
Thank you, Ahmed. Actually, we work on this issue since maybe 10 years ago. And it came the chance for me to be a member of the Supreme University Committee for COVID-19, led by the Minister of Higher Education and some very high caliber of colleagues from Faculty of Medicine and other institutes. And we raise a question again. We need, the CDC Egypt. And we work on this issue. And I think Dr. Ghada Radwan was with me, and Dr. Ali Zaki and other colleagues, Dr. Haitham Amer and Dr. Ghida, and all of them support our view. And we raise a written project for the Minister of Higher Education, and he promised me that it will see the light one day. We hope so. Still, I'm optimistic, but in Egypt, the things go very slowly. But I believe in the proverb, "Go slowly but sure." I hope that one day my dream will be realized to have CDC Egypt. We are.
The old people.
I think Egypt deserves that.
Yes.
We have a very intelligent scientist, and we have a good people, and they all want to work. They are very euthanized and very nice. But the problem that the financial support and the bureaucratic issues, the fighting between Ministry of Higher Education and Ministry of Health. But we write that we need this CDC to will be independent, not to be related to any ministry, to be free and to do the goal of this CDC. Hopefully that it will see the light one day.
Yeah. So I would like to thank Professor Shalaby, Professor Munir, and Professor Radwan for being with us in this session and sharing their ideas and thought. I see many questions here, but I'm so sorry, we have a limited time here, and I would like to give all of you 10 minutes to relax and to go to maybe to the washroom and to stretch your hand and arm. This is very important because we miss in this meeting. And many thanks for all of you. We have in exactly 8 minutes, we will start again with Professor Mitali from India, who will tell you about what about COVID-19, but in the context of other diseases like neglected diseases, other emerging diseases, and other endemic diseases. So,
30 seconds, Ahmed. I would like to thank the participants from Saudi Arabia, Sudan, Nigeria, Ghana, Senegal, Bangladesh, United Arab Emirates, Libya, and Morocco for their participation in this very interesting symposium.
okay.
And thank you, Ahmed, as well. You are one of the.
We didn't. Okay. Good. So many thanks. With ending with life. So take your 7 minutes, relax, and then let us start again with Professor Mitali from India. See you in a minute.
Bye.
Okay.
See you.
Bye.
Bye.
Many thanks.
Mitali, you need to lower the camera a little bit that your face appear.
Yeah.
That's great. That's great.
Okay. And can I just check that the share screen is coming?
Yes. So Mitali, we don't hear you anymore. So I don't know, maybe stop your camera.
The my microphone. Wait.
Yeah, so I think your camera just freeze. I think maybe if you have the camera and the share screen together, it will break. So I think you need to stop your camera and only share screen.
Okay. Is it okay?
So now you can share screen. So we didn't hear you. So this is a.
Yeah.
Yes, now I'm hearing you. Yes.
Now you can hear me?
Yes, now you need to share screen.
I see.
You need to share screen, please.
Share screen. Okay. You are screen sharing. Is that all right? Can you see?
Yes, now everything looks great.
Okay, so you can see me and hear me.
Yes, we can see you.
Okay. All right. Okay, so I'm ready.
So exactly 12 o'clock, everybody. So we are happy that we start again on time. Mitali always said that I'm Egyptian with some German genotypes. But anyhow.
You're Egyptian genotype with German phenotype.
Okay, good. So we are extremely happy that we have Mitali today with us from India. It's too late. I'm sure this is almost the
Good time. It's 4:30. I have my cup of tea ready.
Okay, good.
Tea time.
It's tea time. So she is from the Department of Pharmacology Institute of Postgraduate Medical Education and Research in the very nice, beautiful Kolkata in Eastern India. We are happy to have her with us. I think I will not speak a lot now and let her have all the time to tell you her story. And it's very important to listen to her because she will tell you not about coronavirus, but how coronavirus can affect other diseases. She always optimistic about this, but let us hear. Okay.
Okay.
Mic is yours, Mitali.
All right. Thank you very much, Ahmed. It's always a pleasure to interact with an audience which comprises virologists, microbiologists, probably clinical pharmacologists, and perhaps also clinicians. So I'm a limited edition, and I'm not a virologist. I'm not a microbiologist. I'm not a tropical medicine expert, but I'm just a simple pharmacologist who likes to, straddle multiple cultures. So while I straddle these cultures, I have been looking at a neglected tropical disease, which I would like to tell you about. It's called leishmaniasis. It's called Kala Azar in India. And I would like to tell you of how the COVID pandemic has actually impacted on leishmaniasis, which was at one time an epidemic and now is reasonably under control. So I've titled my work, and I'll go along as I say it. What I would like to say is how basically the control of leishmaniasis is influenced by the present pandemic. So what's important is, what is leishmaniasis? So leishmaniasis is essentially a parasitic disease caused by the parasite Leishmania. It manifests in multiple forms. It could present as a cutaneous lesion, which is a simple lesion, which you actually have in the Middle East. You can see a number of cases like this. In Latin America, you can have involvement of the mucous membrane, in which case it becomes a mucocutaneous leishmaniasis. But what happens in India really is there is a generalized enlargement of the liver and spleen which takes place, because this parasite lives within macrophages and multiplies there, and so multiplies within the liver and the spleen. And what's very important, which I'm going to be talking about, is that it has a dermal sequel, which is called post-Kala-Azar dermal leishmaniasis, or PKDL. Leishmania comes under the world's 20 neglected tropical diseases, and something which is neglected, it's even more neglected when there is a pandemic like COVID, which is occurring. So what really, if I need to go back in time to tell you a little bit about how this epidemic came under control. So in the early 1880s, there was actually a mysterious fever which started in the northeast of India. And they really didn't know about it because all they knew about was malaria at that time. So they called it, they said, we don't know what this fever is, but it is resistant to quinine, which was the drug which was given at that time for the treatment of malaria. And this occurring of fever occurred in millions of people in the northeast of India, and then spread and came into West Bengal. And later on, it spread to other parts of India, especially eastern India, and even in some parts of southern India. We still didn't know what it was about, but the enemy was identified, and the enemy was identified in 1903 by William Leishman at the Royal Nutley Hospital in London, where in an autopsy he identified these little artifacts within macrophages. And he didn't at that time give it really a name. And later on, in the same time, 6 months later, Charles Donovan, who was a professor of physiology, he sent a similar sketch of parasites that he had found in a patient who had huge enlargement of the spleen. And he sent it to a very famous tropical medicine expert, Sir Ronald Ross. And Ronald Ross realized that Leishman and Donovan were really looking at the same thing. And therefore, to honor them, he named the body as Leishman-Donovan bodies. And so this is really the causative parasite that we have. This is the Leishman-Donovan bodies, the LD bodies as they're known as. So what really is, how did I come into this kind of work? So these Leishman-Donovan bodies were identified in the individual. He came from, this is a map of the city of Calcutta where I live. This is the river that is there at the western end of the city. And you have in the north, you have Dum Dum, where the first autopsy patients was identified, the LD bodies. And this is the School of Tropical Medicine. The School of Tropical Medicine is where most of the work on tropical diseases is done. And this is the institute where I am based. And I'm proud to say that Sir Ronald Ross did his work here. So he did his work, his phenomenal work, where he proved that the Anopheles mosquito was responsible for the spread of malaria, that he did this work in my institute itself. So coming back to Kala-Azar in India, down the ages, you can see that what really happened is in the mid 1950s, there was a lot of work going on with insecticide residual spraying. And they realized that if they sprayed with DDT, they were able to interrupt the transmission of the disease. So this was the first control measure that they used. And they used this both for malaria and they used it also for leishmania. By the 1970s, there was actually a withdrawal of this indoor spraying, and there was a buildup of the sandfly populations. And that led to an increase again of the appearance of Kala-Azar, and they were also resistant to the existing drugs. In the 1980s, it spread even further, and there was involvement of 4 main states of India, which is Bihar, Jharkhand, West Bengal, and Uttar Pradesh. In the 1990-91, there was an active campaign, and again there was insecticidal spraying which was initiated. And by 1995, what was very good was there was a decline of almost a 70% decline which had occurred in the annual incidence of cases, and an almost 80% decline in deaths. So once we had reached this really good target, I think, if you're able to bring about an 80% decline in deaths, I think that's very nice. And so the governments of India, of Bangladesh, and of Nepal, they came together and they came up with an elimination program, which I'll be talking about. But unfortunately, when we stand at 2023, we still we have really not achieved our goals, and I'll talk about that. But why did they think that they could control this disease? Why did they believe that elimination was achievable? Because the only host of this zoonotic disease is actually man. Man is the only host, and also dogs in other countries. Sandfly is the only vector responsible. There are excellent rapid diagnostic tests which are available. You have excellent drugs which are available. We have a single dose of liposomal amphotericin B, which can actually bring down, it's a single dose and is now used for the treatment of visceral leishmaniasis. And the geographical spread is very limited. And most important is there is a very high degree of political commitment. So that is why we've always believed that we will be able to control this disease. Unfortunately, we've had a very series of delayed targets. As I said, in 2005, they said, okay, let's set ourselves a target that by 2010, we'll be able to bring down the number of cases to 1 per 10,000 at population at a district level. Excellent. 2010 came and went. Unfortunately, we were nowhere near achieving the target, and we had another problem, and that was that of resistance to the existing drug, which was sodium antimony gluconate. They extended it further to 2015, and here is where they realized that the dermal sequel, which is post-Kala-Azar dermal leishmaniasis, is possibly the disease reservoir, and then they recommended that active surveillance be actually undertaken. 2015, the target was set for 2017. 2017 came and went, and they said, okay, the London Declaration of 2020, we'll have eliminated the disease by then. But again, we've shifted to 2023. And I believe the reason why we've had to shift it to 2023 is because we didn't pay adequate attention to post-Kala-Azar dermal leishmaniasis, which is perhaps the silent disease reservoir. And I hope that by 2023, we'll be able to achieve it. So why is it called the silent disease reservoir? We need to know this. We need to understand what is the pattern that we have of Kala-Azar. So here we have is over the years, the number of cases that we've had of Kala-Azar. And you can see clearly that there is a waxing and waning pattern. So you have peaks and then you have troughs. You have peaks and then you have troughs. Here the peak is much less, the trough is also much lower. And as we've come closer and closer to elimination, we still have peaks, but we also have troughs. And what's worrying is that there may again be a resurgence of the disease. So to understand why this particular waxing and waning pattern is, it is possibly they are considering that the disease reservoir is still existing, and that's what accounts for the re-emergence. So this is what post-Kala-Azar dermal leishmaniasis or PKDL patients look like. So they have these skin lesions which are in exposed areas. So you can see this person has these lesions on the skin. They're full of parasites. So the sandfly can come and take a little bite over here, takes a nice blood meal from here, and then goes and infects everybody in the community. So what's important is we need to realize that if we are to control or eliminate leishmaniasis, we need to actually actively treat these cases of PKDL. And this is really where I have been very actively involved. And I'll tell you a little bit about the work that we've been doing with regard to this elimination program. So once we realized that PKDL is really the neglected component of a neglected tropical disease. And why is it a neglected component? It's a neglected component because all we have is skin manifestations, and often they will not go to a tropical medicine person. They will actually consult a skin specialist who may never have previously seen a case of PKDL because it's relatively rare. And so it's a rare disease. The other problem is that it's often confused with leprosy and other skin diseases. So this poor person ends up getting treatment for leprosy and the parasites continue to multiply. These individuals do not seek treatment readily because it's only an aesthetic problem. It's not life-threatening. There is no reason for them to want treatment. And the treatment itself is not the most pleasant of treatments. It's a very prolonged treatment. It's almost 12 weeks of miltefosine. Side effects are a lot because it's actually an anti-cancer drug which has been modified to treat PKDL. And so you have to have a strong motivation to actually complete the treatment. Please remember, this is a poor man's disease. a poor man who has to think of where his next meal will come from. He needs to go and really work hard for getting the next meal. And for him, treatment of PKDL is actually a luxury. So if we don't, however, form the elimination program, if we don't treat PKDL, we will never be able to eliminate the traces of leishmaniasis. So the laboratory diagnosis of PKDL, it's not easy, believe me, because it's based on usually on clinical suspicion. So you have a history of Kala-Azar or visceral leishmaniasis, you have come with nodules, you come with papules, or you come with extensive hypopigmentation, then people will suspect that possibly this is a case. There is antibody-based detection, but always remember these antibody-based detections will actually pick up the antibodies for visceral leishmaniasis too, and you will not be able to distinguish a previous episode of VL from this fresh occurrence of PKDL. So what is the best way to detect PKDL? The best way is actually an antigen-based test or nucleic acid-based test. Microscopy is difficult. Often you cannot identify it in the skin biopsy. Parasite culture is really very difficult to do because often it's in the facial area where there is a lot of staphylococci already present. So PCR is the only method that we have where you identify, where you amplify the gene fragments and you identify the presence of the DNA, parasite DNA. So the active surveillance program, which was begun in 2015, really was the game changer for PKDL. So earlier what we used to have is we used to have individuals who came to the local district hospital, and that was passive surveillance. They self-reported. So these would be cases who would come with lesions. Usually they would be nodules or papules or macules. It was only in 2015 where Kala-Azar became a notifiable disease, and that's where active surveillance was initiated. What is this active surveillance about? It's a door-to-door survey that is done by local health workers. And in West Bengal, where I stay, they adopted a camp approach. So what was really this camp approach? I'll just show you a slide which explains it all. So this was the leishmaniasis elimination program that we have been implementing since 2015 in West Bengal. So what they do is they do a door-to-door survey where they ask people, have you had Kala-Azar in the past? If you have had Kala-Azar in the past, do you have any skin problems? Do you have any loss of pigmentation? Do you have anything on your skin which you would like to show the doctor? Then they are examined by the Kala-Azar technical supervisors. They identify the suspected cases of VL as well as PKDL. They come to the medical camp. Our doctors from our institute and other institutes, the School of Tropical Medicine, they then collect the biopsies from these patients for the PKDL cases, and for blood is collected for cases of Kala-Azar. Then they are brought to our institute where we either do a PCR or we do a quantitative PCR where we quantify the amount of kinetoplast DNA. We send back the diagnosis that we have reached, and then they are either given ambisome, amphotericin B, liposomal amphotericin B, or be given miltefosine. So this has been working very well for the last few years, and we have had considerable success. And this is where really is when COVID-19 occurred. This was where it had really a major impact on this entire elimination program. So at ground zero, these are the wonderful people who actually work. These are the doctors. So this is Dr. Manav Ghosh. This is Dr. Xuejun Chaudhary. This is Dr. Bikash Sardar. These are our Kala-Azar supervisors, and they would be going to doing these field visits. So if you look at what happened with the active surveillance cases, you can see over here in Bihar with active surveillance, there was a huge surge in the number of cases of PKDL. In Jharkhand too, there was a huge surge, which is still going on, where there is a decrease in the number of cases of Kala-Azar. In West Bengal, the scenario is slightly different in that in West Bengal, because we started a little earlier, we were able to actually identify the cases by 2014-15. And we are now at a point where we actually have a steady number of cases, and we are almost close to achieving the elimination target. So we do believe we can do it, and we have excellent nucleic acid diagnostic tools, which actually began in our lab. There were other workers too who have worked on it. So this is a PCR where you can see that query cases of VL were picked up. we ran a positive control, which was the parasite AG83. And similarly for PKDL cases, we had the positive control and the suspected cases of PKDL, which also came out to be positive. But this was not good enough for monitoring treatment, because what they wanted, what the elimination program wanted is, please give us a tool which tells you whether the parasite has been completely eliminated or not. So whether you have 100 parasites, or whether you have 1,000 parasites, or whether you have 10,000 parasites, they will all come out to be PCR positive. So you will not be able to tell what is the number of parasites. So then we developed a qPCR based, which was based on the kinetoplast DNA, where we identified the cycle threshold. The CT values were obtained. And based on the CT values, we drew a standard curve, because we gave a fixed number of parasites per 200 microliter of blood, and we obtained the different CT values. And using this standard curve, we would put the CT values from the patients who had either received treatment or were naive cases, and then be able to identify what is the exact number of parasites per microgram of genomic DNA. So this is very important for the elimination program, and this is what we have been doing. So now comes to what is really the influence of the disease epidemics on the control program of this neglected tropical disease. So as you can see, the major pandemics that we have had, and so we need to be prepared for the fact that in the 21st century, we have had 4 pandemics which have occurred. And so this is really very worrying. And so we need to be prepared for even another one to come in the next few years. So leishmaniasis is a neglected tropical disease. Many of them, many entities are for zoonotic nature, and so is coronavirus, an emerging zoonotic disease. And both, of course, as we know, represent a public health threat. If we look at the death toll, so this was an old slide that I found, and this was the data, which was 4.7K, which was 4,700 of COVID-19 in March of 2020. But I need to show you the data as of today. It's really worrying. So this is where we stand with the number of deaths, okay? We're just below the plagues. We're just a little better than the Asian flu. So this is a really worrying scenario, and we should wake up. And of course, as my previous speaker said, is hopefully hope is around the corner and the vaccine will be available for us, because this is really a very worrying trend that we have here. So what is the WHO directive in the context of COVID pandemics? The specific considerations for the elimination program, what they have said is community-based surveys, mass treatment, and active case finding should be temporarily suspended. So you can imagine how difficult it is for us to continue our elimination program. And they are saying that you should monitor and reevaluate at regular intervals the necessity for delaying these activities. So this is really a major setback for our elimination program, because the active surveillance program has been stalled. We are not able to detect new cases of PKDL because we don't have an active surveillance. They are not coming to the hospital. And of course, we will not be able to achieve the elimination target of 2023. So this really is because all the healthcare workers that we have who were involved, the Kala-Azar treatment supervisors, they have all been directed towards treatment of COVID-19. So this really is a very major setback, and I don't know when we will really recover from this. Would elimination of VL be affected? I believe it will not be affected, because these cases actually present with fever, and perhaps with the COVID-19 pandemic ongoing, they will probably receive treatment earlier, because they will have access to a real-time PCR for COVID-19. They will turn out to be negative. And when they turn out to be negative, they will consider doing an RK39 strip test. And so they will have access to prompt treatment. So I don't think the elimination of VL will really be affected. It will still continue at the same pace. But as I said, it's not elimination of VL, which is the last mile challenge. It is the elimination of PKDL, which is the important challenge. And that will definitely be affected, because PKDL needs prolonged treatment. The compliance will be hampered. Drug resistance may also occur. And we will definitely end up in a few more months, probably when we go back to the field, we will probably find that many more cases of PKDL have emerged. And we hope that funding agencies will realize the importance and will again continue to support the elimination program, support the research and development which is going on. It's very, very important if we are able, if we do continue if we are to sustain this elimination program. In terms of the molecular diagnostics, I think there has been an amazing improvement. The availability, the speed at which there was availability of diagnostic approaches for COVID-19 was something which was absolutely phenomenal. It's done, as we know, by detection of viral nucleic acid or by detection of antigen. So how did this help in the elimination program for other entities? I think it helped because we now have a bandwagon of experts who can do RNA extraction, who can do PCR. And I think this is the good side of it. So we should be, in a way, be grateful for COVID-19 being such a disease with high morbidity and mortality. It ensured the availability of rapid diagnostic tests. It ensured the availability of cheaper tests also, which are being done. And so it's important that we use these molecular diagnostic approaches, we adapt them for doing work on diagnosis of PKDL. So will NTDs, they should not be neglected, because we believe that the COVID-19 will exacerbate the NTD situation, because there will be diversion, and there is diversion of financial and human resources. There will be, I'm sorry to say, a reversal in progress achieved in NTD control and elimination efforts. I believe that COVID-19 will push a large proportion of human population into poverty, because their NTDs, if they are suffering from NTDs, they will be ignored. And so it is absolutely critical that alternative strategies are needed to ensure the gains that we have brought about with NTD control and the elimination programs, we are able to sustain it. It's very, very important that we actually do it. But I end on a note of hope. So like the lotus flower, which actually lives in muddy water, we too, as humans, have the ability to rise from the mud, bloom out of the darkness, and radiate into the world. So I do believe that we will have the knowledge that we have gained from COVID-19, the research efforts that we have gained from COVID-19 will go towards better availability of a vaccine for COVID-19 and perhaps a vaccine even for PKDL. We would be able to extrapolate the knowledge gained from the COVID-19 vaccine development programs, and we will also have better diagnostics, we hope, and we will also have trained manpower, because the diseases where the NTDs occur, we do not have trained manpower. So I'd like to end on this note of positivity, and I'll be happy to take questions. So should I just stop the screen sharing, I guess?
Yes, many thanks, Mitali. You have just taken us in completely different
right
room, where, because I know that biologists think, oh yeah, parasite is different thing. The parasitology don't want to hear anything about the other diseases, but you just wake up that as a human being and as a virologist and as an infectious disease expert in medical field, in other field, there are need to know that there are neglected disease, and it's very important that, as you said, that there is some neglected part of the disease inside the neglected disease, which we always neglect. You see that there are silent reservoir. It's exactly the same scenario like asymptomatic cases in the coronavirus. And
yes.
You see this with your door-to-door surveillance and drug administration. You were able to control a disease which nowadays it can be a big problem for the control program and really go further. But as you said, a very good advantage. We have trained people.
We shouldn't cash on it.
Yes. We have trained. You have a lot of molecular diagnostic available everywhere nowadays. The people start to see the importance of molecular diagnostic and how this is an advantage. And sometimes they have also drawbacks. But anyhow, this is a very nice, great outbreak idea to tell the people that they must focus on. So I need to receive questions via chat. I'm sure the lecture was very clear and with very clear message, the pros and cons of having COVID-19. But if anybody has a question, it's very important to ask now because we still have 3 minutes.
think it was an exotic disease for the audience.
But this is very important because you usually, everybody live in its own room, which is own.
No, I mean, if we think about, the vaccine story, and we think about how could a vaccine come out in 10 months, it would not have been possible if we didn't have the knowledge of vaccines from other diseases, which was actually extrapolated. I think that the Oxford group had already been working on the SARS vaccine. So that's how I think we were able to, make this huge jump. Something which takes 8 to 10 years, a vaccine to develop, we are doing it in 8 to 10 months. And this is only possible if we learn lessons from other diseases.
So the other question is that, what do you think about, there is from Abdullah Sami, he did a lot of work on Leishmania, especially in Egypt, and he said a very important question now, that what do you think about the effect of climate change again on neglected diseases, especially Leishmania?
Absolutely, it's a very relevant question that you've asked. And what we are finding actually is, because of the effect of climate change, what is happening is there are new spots which are actually appearing, because the sandfly is moving into different environments, which is, so now what's happening, especially in Nepal, that they have found that people living at much colder climates, which we knew were areas where sandfly would not be able to grow and multiply, they are actually having new foci are actually appearing. So climate change is an extremely important component for the expansion of vector-borne diseases, and we need to keep that in mind. We need to actually emphasize that vector-borne diseases, the influence of climate change on vector-borne diseases. So thank you for bringing it up. I think it's an extremely relevant question that you've asked. And we actually have seen in Nepal appearance of new foci, and these new foci are actually linked directly to climate change, because the area over there has become, the temperature has actually risen by a few degrees, and this makes it suitable for the sandfly to actually grow and multiply.
So you have your first collaboration, Abdullah Sami again, he would like to tell you that he will happy to collaborate. He will send you
of course
email,
yes,
because he's doing modeling also in Egypt, Leishmania stuff, and he would like to really collaborate on how the and Leishmania in India can.
Absolutely.
Yes. Okay, that's good. So many thanks, Mitali, for this.
Thank you for this opportunity.
No, this is we are very happy to hear the neglected inside the neglected. This is a very important message.
But must not be neglected.
Yes, of course. And also important that we have also that the bright side of having coronavirus an effect on the scientific life. Many thanks for being with us.
Thanks.
It was an honor that having you with us here, and I'm sure we will have another meeting, and we have also you from India to Egypt to India or other countries. Many thanks, Mitali.
Thank you.
So now, since we started this, Mitali has mentioned a very important thing, which is diagnostic and availability of rapid diagnostics and molecular assay. And for that, I would like to have Professor Dr. Manfred Weidmann from Brandenburg Medical School in Zinfenberg, Germany. Actually, I think many Egyptians know Manfred because he has trained many scientists from Egypt during outbreak situations, especially the foot and mouth disease virus. It's an animal virus. And I must admit that Manfred's principle is like this: try to give the tool to the people and let them do it. And I need here to mention that, and this is Martin Fife from Pasteur de Dakar is here also, that the first Ebola case identified in Guinea during the West Africa Ebola outbreak has been identified with a mobile laboratory which Manfred Weidmann and his colleague established and trained people in West Africa. So this is how establishing such tool in poor resource setting can lead to identify of horrible disease like Ebola virus. So now I will ask Manfred to join us and start his presentation.
Hello, everybody. Thanks for attending my lecture here, Current Insights into the Performance of COVID-19 Diagnostic Assays. As already mentioned, I'm currently a guest scientist at the Medizinische Hochschule Brandenburg, but for 5 weeks now, I'm also an employee of a diagnostic company called Medical. I'll be briefly talking about performance of PCR assays and of antigen assays, and then I'll expand a little bit into Ahmed and my collaborative work on RPA assay development. Shortly after the outbreak occurred, the first paper publishing 3 target regions for the SARS genome was published, and as you can see, they were mostly located towards a 3' end. And if you check the, oops, it's not moving. Sorry. So if you check the Fine Diagnostics pipeline these days, you will see that there's an incredible amount of PCR kits available, and quite a lot of them have been actually fully CE-IVD marked. The same for automated PCRs, and there's even 9 LAMP kits, quite a few antigen kits, and many more antibody kits, but I'm not talking about antibodies today. The issues that happened or that occurred in the initial phase were contaminations with positive controls in some of the first kits. Those were solved. There were specificity issues with some of the e-gene RT-PCRs, and there was an ongoing discussion about false negative sensitivities, false negative tests, meaning the sensitivities of the assays. So if you look at the published RT, the available RT-PCRs, and do your limit of detection analytical sensitivity, you'll see that most of them have very high analytical sensitivities in the copy range. And if you test them with clinical samples, like in this paper by Van Kasteren, you more or less see that they perform almost at the same level. So the best one here ticks 13 out of 13, and the worst one 10 out of 13. There's more papers like this from China and another one from Europe here, looking at various PCR kits, but the message is always the same, they're very sensitive. However, if you look more closely and look at this paper, which analyzed the RT-PCR performance by time since the symptom of onset of exposure in 7 studies, which altogether looked at 1,330 samples, all upper respiratory tract samples, and checked the scores with the actual clinical data, you could see that the probability of the PCR being negative, although the patient is actually infected, is 100% in the first onset. That's clear because the viral load is not detectable yet. And then it begins to drop as the positivity rises. However, even in the first days, up to 20% of samples, or the probability that test might be negative is about 20. And then it slowly rises again towards the end of the disease. So very early on, it was quite clear that you cannot rely on RT-PCR alone, but you have to take into consideration clinical data and other diagnostic tools such as lung scans. Now, in this epidemic, it's been an unprecedented sequencing effort going on. On the GISAID webpage, you can find 193,000 full genomes of 205,000 submitted. And this is a representative star plot of 3,300 sequences representing all major subclades. And as you can see from the colors here, Asia, Africa, Europe, and so on, they're fairly well distributed. Some clades are dominated by some colors, but the message is most of the strains are everywhere. Now, this sort of data you can use to analyze the mutation rates at known primer binding sites. So you can see this is the PCR I mentioned first from the Charité, the e-gene, several other amplicons listed here. And these are the number of mutations within the primer region. And down here is a more close analysis of whether these mutations are actually in the 3' area of the primer, which, as we all know, is the most important part of the primer. So the message is, yes, you can monitor this. And there are some kits which you have to look at more closely. But it's a good way of keeping up with the developing subclades, for example, in the one that was identified in Spain and the other one in minks. But, you know, if we have RT-PCRs at high analytical sensitivity, what are they actually detecting? So in this study by Ballard, which is also from spring, they were looking at comparing CT values and culture TCID50 to see for how long they could actually isolate viruses from the patient samples. And you can see here after day 7, they couldn't find anything anymore. And if they looked at cycle threshold and probability of the culture being positive, one can more or less say anything beyond CT30 indicates samples which are not, or samples from patients which are not infectious anymore. There's been a recent review just 2 weeks ago, last week in The Lancet, that has done a literature study across many papers and have come to the same conclusion. And there are also several other individual papers. Basically, the message is, well, in the first week after onset of disease, people are infectious, but after? Now, if the sensitivity in general is 10 to the 3 molecules per milliliter, and we now have seen that viruses are not infectious anymore in the sample, so what are we detecting? Now, if you look at the SARS genome, which is a single strand, a positive strand virus, which has subgenomic RNAs generated through transcription at the 3' end, generating this gradient, and you use species-specific PCR to detect these subgenomic RNAs, you can actually find them up to day 17. And down here is a histograph of trying to put a picture to the quantities of these subgenomic RNAs that were found, and it reflects the gradient, which is shown up here, basically telling you that the PCRs are not only detecting the virus genome, but also the subgenomic RNAs. This leads to an actual viral genome overestimation by 100 to 1,000-fold. And this may explain why there is an extended PCR positivity of some samples. Everybody's talking about CTs going up to 40. And it may also explain discrepancies in results of different diagnostic PCR methods in low virus load samples. So the PCRs are highly analytic, have high sensitivity, but they detect more or less too much. And while patients remain positive, although they're not infectious anymore. Now, what does that mean for antigen tests? In this study, which just was published 1.5 weeks ago, I think, a group looked at 7 CE-approved antigen tests on the market. They took a cloud of 138 real-time PCR quantified samples they had in their stock, with an average of about 2.4 times 10 to the 6 copies per mil, and then they tested the antigen test. So the blue bars are positive, the red bars are negative, and white bars are not tested. And they found that in the 5 best tests, the sensitivity was 4.6 times 10 to the 6 copies per swab. So they did a calculation down from milliliters to swab, but they also found that the specificity when they tested 35 healthy patients, that across the 5 tests, they had a specificity of only 93% because they had several pickups, so false positives. So the conclusions from their study is actually that these antigen tests are useful in the first week of symptoms, and they're actually helpful to determine the end of the factor transmissibility, because this value more or less means by the time you reach the limit of detection of an antigen test, you reach the limit of infectiousness in the patients themselves. So these tools could be used to isolate or maintain isolation based on infectivity testing and not on infection screening. However, there's a remark that the various kits have different confections and they need to be changed and optimized, so they could actually be used by consumers themselves as home tests. So they created this term consumer grade test. Larimore here did ask himself, well, what happens if you use tests for asymptomatic individuals. So we all know that clinical testing needs high accuracy and sensitivity. But what happens if you use these types of tests in asymptomatic individuals? So here's a computer simulation. This is sort of a standard ideal COVID trajectory rising up to here, sort of 3 days after infection. The tests usually happening around day 6, sort of 2 days after onset of disease. And there's loads of variations here. And they did the simulation and looked at the analytical sensitivity cutoff of 10 to the 5 per mil and 10 to the 3 per mil. This would be a PCR and this would be published LAMP assays sensitivities. And they asked themselves, what does the surveillance effectiveness, what does the model of this effectiveness do in respect to test sensitivities, frequency of testing, and speed of reporting? If you look at this upper graph here, the impact of the surveillance was studied in 10,000 individuals, and the colored bars shows you the number of infectious people you're taking off the street if you sample daily. Now, the hatched bar here is if nothing's done, they just assume that this amount of people would self-isolate on their own, just without any test. And as you progress here through the timeline, you test every 3 days, you test only weekly or only every 2 weeks, the number of people who are infectious you're taking off the street is obviously declining, while the number of people who self-isolate more or less stays the same. Now, if you ask yourself now, what does that mean for the infectiousness of the individual patients? They took their simulation and recalibrated it for 100 people, looking at which one they would miss and what would be their individual infectiousness. This is an arbitrary score. Now, you've got the same timeline. You can see that after 3 days, you sample cohorts who are positive, who would have about this level of infectiousness. If you only test them every week, the infectiousness would rise. And if you only every 2 weeks, you see the blues here coming up, those are the people you're missing, it's getting worse. So altogether, I'd like to point out that the difference between the bars here, whether it's an LOD of 10 to the 3 or 10 to the 5, is not very much. It's almost the same in both types of calculations. So they come to the conclusion that for surveillance should prioritize accessibility of the test, frequency of testing, and sample to answer time. Because if you have the sample on the spot, let's say 15 to 30 minutes after you're testing, you can isolate that particular patient on the spot. And that has the greatest effect. And that analytical sensitivity is actually secondary. So I'm coming to my final section. We have been looking at this RT-RPA assay development for the suitcase lab, which was already mentioned. We targeted the same regions as in that initial PCR paper from spring. We did cross-detection studies with a host of human respiratory virus and veterinary respiratory viruses, and we only get detections of the SARS coronavirus types. We did analytical sensitivity and probit analysis, and there you see quite nice analytical sensitivities comparable to PCR results. We also managed to test some clinical samples of the University of Leipzig. That's 36 patients, 16 positive and 16 negative. Here are the PCR results for this y-axis, and these are the RPA results on that axis, and those are the 3 RPA assays. And that one, actually, the RDRP turned out to be the best one in terms of clinical sensitivity, specificity, and positive and negative predictive value. And actually, the red dot here is the only one that this RPA missed. That's the one that comes in here and that causes this sensitivity value. So this needs to be evaluated with higher numbers of patient samples. And this is exactly what we're trying to do. Ahmed was successful in obtaining an EDCDP project called Multi-Country Blinded Study to evaluate the suitcase lab for rapid detection of SARS coronavirus. And you can see loads of African partners in the project and an associate partner here in Egypt. And the plan for the study is to do a semi-blind prospective study. The teams will be split in two. One will test PCRs and report them to the coordinator. The second half will test RPA blind. They will not know the PCR results. And we're targeting 500 samples per country, which would give us a nice overall number of 4,500. We'll test the suitcase laboratory with the Axiom T8 device, as we've done previously in our field trials. And the schedule had actually been from September to February, but Ahmed only got the grant agreement signed from EDCDP yesterday. Now, the plan for this test would be sampling, you lysis in one tube, you do your RPA in a second tube, you pull in your lysis sample and you put it on this device in the suitcase lab. Now, the company I've been working with for 5 weeks now is trying to adapt this by developing a very small fluorescence reader and a consumable here. And the consumable has 2 chambers, an upper chamber for dipping the swab into for the lysis. You then twist this consumable, you put it on the reader, you twist it for quarter rotation, which then transports some volume down to the lower chamber, which contains the RPA reagents, and you can read out the result with your smartphone and report it to the public health system. We're working very hard on the system. We're hoping to come out in spring. I'd like to acknowledge University of Leipzig and Medizinische Hochschule Brandenburg as partners in this project. Here are some of the other German partners I've not yet mentioned. The African partners, of course, I've just shown you in the table, and funding is by EDCDP, and there's some additional funding to this project by Midge Medical and by Tip Molbiol in Germany. That's it. Thanks for your attention. I'm open for questions.
Oh, many thanks, Manfred. For the sake of time, we have done this, that we can take question at the end of the session. Are you staying with us or you will leave?
When is the end of the session?
So we have it in another 1 hour, in 1 hour.
I'll be there for the question time.
Okay, many thanks, because we need to move. Many thanks, Manfred, for this nice overview about the diagnostic, how the PCR can produce reliable result, but we need to re-evaluate what's come out from PCR in order to get a clear clue about positivity rate and negativity rate. So now I will move to our next speaker from China, Professor Dr. Ma. He is the director of the core facility for the National Institute of Viral Disease Control and Prevention in China. He did a lot of work on point of care, on point of need rapid diagnostic, and he will come with us to share his experience, the China experience in this part. And for that, I would like him to start his presentation. So the mic is yours, Ma. So I think you need to unmute in order that we hear you. Yes, we hear you now.
Now you hear me. Can I start with the sharing my screen? Okay.
Yes, your screen is shared. Yes.
Let me see.
We see a Chinese tickets from Zoom, but you can also share your PowerPoint, of course.
Okay, let me see. SharePoint. How can I share the point? Let me see. What is that? Sharing. Oh. Excuse me. Just a second.
No problem.
How about this one?
So you
yes, I got it.
No, so far I think maybe you are working with 2 screens. Yeah, this is what I'm supposed to do. This problem always happens if you are working with 2 screens. Can you move? Can you open the PowerPoint and then make it full screen? Then we will all
Okay, so you see us, you see my PowerPoint slide?
Not need. You need to share screen. There is a green button.
Okay, okay. Let me see. Okay. Let me see. Sharing. Sorry.
No problem. Take your time.
Okay. Sorry. Let me see.
You can also send the presentation by email, and I can share it from my side if you have a problem.
Okay. Okay, that'll be fine. Let me send you email. Okay.
Okay, that's good.
Wait a second. Come on, come on. Yes. Okay. Here we go.
For all participants, if you would like to have questions about diagnostics to Manfred or Professor Ma, please prepare your questions via the chat option in order to keep you updated on either the lecture will give by Manfred and also the presentation which will be given now by Professor Ma.
Where's my slide? Let me see.
The people motivation, because we have a lot of questions at the beginning, but now everybody's sleeping. I don't know why we don't take a question since.
Okay, I sent it already. Please check it out.
Okay.
Professor Amer.
Okay, so I'm now. I didn't receive it so far, but it will be anywhere. So maybe it's crossing a lot of countries until it reaches us. Oh, yes, now I have it.
So you have it? Okay, great.
Yeah, so I will now share it with everybody. So just a minute. So I can do it from here. Many thanks.
Sorry for the delay. I really appreciate it.
Now you see it, I think.
Okay, gotcha.
Yes. So please go ahead.
Okay, sorry for the delay. First, I would like to thank for the invitation of Professor Ahmed. So I have this chance to share what we have done in the past few months. Just now, I heard the presentation from Professor Manfred. Please excuse me if I pronounce it wrong. He just talked about a little bit about the RPA. So in this case, my topic is about the detection of the COVID-19 using recombinase-aided amplification, which we call RAA techniques. So I'm from China CDC, from IVDC. So let me see. Next slide. Let me see. Okay, so, okay, yes. Okay, let's just skip this one. This is my personal information. Okay, yes, start with this one. So we all know the pandemic of COVID-19. As of today, more than 60 million cases were reported. Of course, early diagnosis and isolation are really critical for the effective infection control COVID-19. In addition to the non-drugs public health interventions like wearing mask, hand washing, and keep social distance. And among all the detection methods, nucleic acid detection is regarded as a gold standard for diagnosis. Right now, real-time PCR is a mainstream technology in the identification of COVID-19. However, the faster and simpler nucleic acid detection are really highly in demand because it is better suitable in field investigation, like Professor said, on the spot, investigations. So next slide, please. 3 different ways. We all know that viral isolation is good, it's very good, but takes a long time and labor intensive. Serological testing, we all know that, say, for example, the antibody detection has a window period leading to the false negatives. As to the antigen detection, because of the lower limitation, lower sensitivity, so resulting in the false negative again. So back to the nucleic acid testing is still the most frequently used one in currently. Let's move to the next slide, please. So what we have now in China, currently, China FDA has already approved 51 COVID-19 detection kits, including 25 antibody detection, 2 antigen detection, and 24 nucleic acid detection kits. Next one, please. As I said, the simpler and the rapider the technology are highly in demand. Although the real-time PCR has already played a very important role in identification, but the isosomal amplification assays are better suitable in the field investigation. Look at this slide. It's give you a very overview of the currently available the most isosomal amplification assays. So we have LASPAR, SDA, LAMP, HDA, RPA, etc. And in terms of the, if you look at the property, the temperature, the number of enzymes, the publications, IP, etc., I would say LAMP and RPA are most popular in terms of the isosomal amplification assays. And to be further, LAMP technology was invented in 2000 by Japanese scientists, while RPA was invented in 2006 by British scientists. And next slide, please. Let's move to the RPA, RIA. So RIA was invented in 2016, which is 10 years after of the invention of the RPA. We have China scientists has an IP. So obviously, if you look at this comparison among LAMP, RPA, and RIA, we would say that RPA and RIA are superior to the LAMP, but the difference, they're almost look at exactly the same thing, RPA and RIA. But actually, the difference between RPA and RIA is the sources of enzymes are totally different. So I would recommend that in terms of this, the simplicity and the rapidity, RPA and RIA are better than LAMP, which has no doubt. Next step, please. Okay, so if we compare real-time PCR versus RIA, we easily can see that the time, the cost, the operation, and the device, the RIA is better than real-time PCR. Next slide, please. So, next slide, please. Next slide, please. Okay. So what definition of the RIA? As we can also say, yes, okay. So RIA is actually, to my understanding, is pretty much the mimics of the in vivo DNA amplifications. So all the reaction are complete officially in less than 20 minutes at 37 to 42 degrees. And we all have the core enzyme literature includes the SSB, the recombinase, and the DNA polymerase. If we add the reverse transcriptase, then we make up with rtRNA. If we add fluorescence probe in the systems, we make up a real-time fluorescent RNA. And the most attractive features, I think, of RNA is we can do equipment-free visual detection by using combined with a lateral flow dipstick, which we called RAA-LFD. Next slide, please. So the principles of RAA. So it starts with next slide. Start with yes. Next. It starts with the recombinase primer complex, and it invades in search for the homologous sequencing of the template, and the recombinase separates the double-strand DNA. Yes, the recombinase invades and apart with the help of the recombinase, separate the double-strand DNA, and the SSB. Next, the SSB binds the separate strand and provides adenine back, and with the help of DNA polymerase in the presence of DNAP, then it's the extension and application occurs. So I think we all know, if we know about the RPA, then basically the principle is the same. So next slide, please. So pros and advantages and the limitations of the RNA: high sensitivity, specificity. We have this conclusion based on our previous works. And of course, the most attractive features is a shorter turnaround time, cost effectiveness with a portable device. There's a variety of ways to read out the results, and all the reagents are lyophilized. Of course, it has limitations. For example, the length of the primary probes requires more than 30 bases oligos, which is longer than PCR primers. And the binding mechanisms of recombinase to primers is unclear, and we are working on these two limitations, try to address these challenges in my team, in our team in the future. We are working really focused on this one. Okay, next slide, please. So talking about the results without, either way is fine. We can use the gel electrophoresis if we don't have the fluorescence detector. If we do have, then we can perform real-time fluorescence. If we combine with a lateral flow dipstick, we can do the visual observation by naked eyes. So there is a variety of ways to read out the RA results. Next slide, please. Okay, so I think back to the 3 years ago till now, we have published like more than about 14 papers using the RNA. I think we contribute a lot in terms of the promotion of the RNA in the world. I think that's our main contributions. And the RNA technology is currently now recognized and acknowledged by international peers. If we look at these papers, mostly we were dealing with the virus, particularly say adenovirus 3, type 3 and 7, like hepatitis B and HPV 16 and 18. Those adenovirus, we can do the simplified extraction combined with a lateral flow disk. We can do the almost POC testings. So with the simplified lysis and the visual observation, so those DNA detection of RNA are close to the POCT. But for the RNA, like COVID-19, we still have a long way to go. I will show you later. Next slide, please. So we have developed quite a few research-only detection kits, and those kits targeting RSV, adenovirus 7, 3, and 7, hepatitis B, and pertussis, TB, such as African swine fever virus. We have already make up the research only detection kits, and they are almost finished the evaluation of these kits. And just before we promoted these detection kits, then we made with the COVID-19 outbreak. Next slide, please. So before that, I think if we look at China, although take it together, currently we have quite a bunch of RA kits research only, either in the field of infectious diseases, respiratory virus, animal disease, parasites, and foodborne microorganisms. We have quite a bunch of these research-only kits. Next slide, please, in China. Next slide, please. So, as I said, we met with the COVID-19 outbreak. Back, slide. Back. Yes. Yes. Okay. Let's stop here. Okay. So, yes. So we started with the research and the development of the RNA detection kits for COVID-19 in January 19th, with a joint developed by working closely with a Qitian gene partner in China, and in January 29, we passed the internal quality panel in IVDC China CDC using 30 clinical samples, and the persistence rate was 1%. And on February 6th, we finished the clinical evaluation with a small sample size, about 300 samples, and compare with the commercial real-time PCR kits, and the persistence rate once again was 100%. Then on April 20th, we again finished a clinical evaluation using a larger sample size from multiple centers with almost 1,000 samples. So again, the persistence rate was 97.78. So it's over 95%. So which is good news for us. So next step, please. Okay. So to summarize the features of these kits, advantages, so it's high sensitivities. Per our standing, the sensitivity of these kits is 20 copies per mile, and we know that the China FDA standard of the China FDA, the sensitivity standards, the minimum requirement is 1,000 copies per mile. So in other words, the sensitivity of RA kits is far beyond the sensitivity of the requirements in FDA. So technically, it's good enough to pass this FDA testing. Though talking about the time, after addition of extracted RNA, you can have your results come back in 8 to 15 minutes after the addition of extracted RNA. And talking about the throughput, you can easily finish 16 samples per run. Of course, using portable devices, and at 39 degrees with portable devices. As I said, the limitation, RNA extraction is not yet integrated in our devices, so which limits its somehow limits the investigation of limit the field investigation on spot. Next slide, please. So this slide shows the whole procedures, how you can finish 60 samples in 45 minutes. So we combined DNA automatic extraction made in China, which can accomplish 32 samples in 23 minutes, and we use a peptide. It takes about 5 minutes to make up the DNA reaction systems, and then we use a mixer. It takes 7 minutes for the mixer, for the shaking and the pipetting mixer. You use a mixer, then we move these 16 tubes to detector. It takes another 8 minutes. So put together, it's like 16 samples in 45 minutes per person per round. So our goal is to have the FDA approval at the end of this year. And currently, we are doing the multiple centers evaluation using an even larger sample size. We are in the middle of this one. We are in the middle of this evaluation. So hopefully, we have our approval before January 1 next year. Next step, please. So how this quite similar to the manuscript Professor Amer and Professor Manfred submitted. We finished the multiple center clinical evaluation of this kit, and this is a summary of the results. So the total coincidence rate is over 95%. The sample is from 5 institutions in 4 regions of China, and overall, I think the performance was quite impressive. Particularly, it's simple and it's rapid enough. Next slide, please. Next slide, please. Okay, so sorry, it's in Chinese, but anyway, this slide shows the official report of IVDC, the poster news in our website. So next slide, yes, this is just the official report on IVDC website. Okay, just give this one. So now we're trying really hard to develop the RNA POCT. We all know it's all in one machine, and our goal is to finish the one sample in 25 minutes, starting from sample in till the result out. And the prototype of this machine will be launched. I think it's at the end of this year. And the proof of concept, we have all passed the proof of concept testing. So hopefully we can have this machine very soon. One sample in 25 minutes. Next slide, please. The features of this RNA POCT, and I think it's obvious, it's well known. So let's just skip this one. Skip this one. Next one, please. Applications essentials. There are lots of the application things, and I think I would say particularly the most important thing is in the customs at the airport and the fever outpatient unit at the country level, because those are the main resources of infection in China currently, particularly the customs at the airport. And if we're able to develop the RA-POCT successfully, we hope this RA-POCT will be used as a self-testing at home. Hopefully, that's our final goal. Okay, next step, please. So we have a bunch of supporting documents. Now we have patents, RA. We have got the CE certificate, and the RA kits is already put on the white list of China's Ministry of Commerce. So it's so in other words, this kit is already exported to other countries. Next step, please. Yes. Oh, okay. So the family trees. This is my team. I would like to thank these young guys for their hard working and contribution to this project. So we logo the tattoo of the of our team is to always not only move forward but making a strong difference. We are trying our best. And next step, please. Next step, please. Yes, in China we have a lot of the cooperative partners. Those partners are from the college, research institute, and the other hospitals and customers. Yes, they did have a lot and work together with us. So I'm very happy to have them to join the RA team in China. And next slide, and I think it's next slide, please. And I think this is the last slide. So again, I thank you for your listening, and I hope we have a chance to work together and to promote the RA technology in the world. And so if you have any question, just let me know. Thank you.
Many thanks, Ma, for this nice presentation and introducing the REA. I think everybody know the LAMP very well, and also the RPA technology, because they are for years, but it's very important to see another stuff which is coming from China. And I think we need to know exactly what the difference between RPA and REA. Everybody will welcome that. So Professor Ma, can I ask you to stay with us, because we have another 2 presentations. They will give us
Sure.
field, and
Okay.
then I will have we will have a general session where question about diagnostic in general with all the speaker from diagnostic part. So stay with us, and many with this nice presentation. Michael Frimpong, he is the next. He is from Ghana. He will have a Ghana experience of having rapid diagnostic. He is sharing his screen now. I see, and then please also use your. You need to open your video. I will ask you to start video, and ask to unmute. So please go ahead. So
hello.
Many thanks for joining us from Ghana in the heart of West Africa. So we are happy to have you. He is a lead scientist for the neglected disease group in the Kumasi Research Center in Ghana. He is a recipient of the well-known CTP grant for young investigator, and he's a very good in establishing career from inside Africa, which make him one of the really great scientists staying in the African continent and doing research from inside the continent and prove that we can do it. So, Michael, the mic is yours.
Oh, thank you very much, Ahmed, for a nice introduction. And thank you also for the invitation, and I'm happy to be here. This afternoon, I would like to share with you our experiences on the field in using a field deployable diagnostic test for COVID in Ghana. And like Ahmed said, I'm Michael. I'm a lecturer in molecular medicine at the Kwame Nkrumah University of Science. So I think I don't need to belabor this point. The previous speakers have shown us the importance of testing in this whole fight against COVID-19. And just to let you know that we only know the people that are infected if we test them. And so if we don't do the testing, then we have no, that is principally what we want, I want to share. This is a slide from the African CDC, just to give us a of how far we've come in this whole fight against COVID-19 in terms of diagnostics. So you can see in January, Africa had no diagnostic capacity, or we didn't have the tests to do any COVID-19. And at that time, I mean, it wasn't an issue for us in Africa. Early part of February, then Senegal and South Africa came on board, and those were the main reference lab to do COVID-19 testing. But in early March, almost every country in Africa has one form of a testing site to be able to do COVID-19 testing. So if you look at this global, this picture in Africa, you think almost every country is covered, except a few countries. But when you go deep into the countries, then that is where the reality hits you. This is just to show you the situation of COVID-19 in Ghana at the moment. So this data is from the 19th of November. And you can see that we've tested close to 50,000 confirmed cases in Ghana, and we've tested close to 600,000 samples. But of this 600, almost 600,000 samples is coming from mainly two sites. So we have the Noguchi Memorial Institute in Accra, which is the capital, and then the KCCR Institute in Kumasi. These are the two major reference labs that are doing the testing. So just to look at the map of Ghana, and you see here where we have Ashanti region that is based in Kumasi. And you see that majority of these confirmed cases are coming from either the Ashanti region or the Greater Accra region. And these are the sites that have the capacity. So even though there are other, positive cases from the other sites, they are limited in testing. So they ship the samples all the way from the north to other Kumasi or to Accra to get tested. And this delayed the testing procedure, especially in the peak of the infection, which was not good for us. I mean, some people were waiting as long as 14 days to get their test results. And we know this is not the ideal situation. Just to show you the trajectory of cases as we've seen from the beginning, from June, which was our peak period, up until now. And we seem that from June, which we had our peak period, the cases seem to be going down. But now in early part of November, we see the cases going up again. So it only tells us that we are not out of the woods yet, and we don't need to relent on our efforts. So these are the challenges that we had in Ghana at the moment, because we had very limited facilities to do the testing. We have two major sites. The government and NIH service are trying to resource their public health labs, but these public health labs are not well structured to be able to deal with an organism like this. They didn't have the safety cabinets and all that to be able to inactivate the virus before they do their extraction. They didn't have the PCR machines available and all that. Also, there is a problem with supply chain. You mostly get support from donors from China to support our testing. And once these are not coming in, then you are at stake. And obviously, because there are only limited testing centers, few testing centers, it takes a long time for the people that have to do long travels to get their samples to the testing sites, a delay in getting their results. And this also results in backlogs, because in the peak of the pandemic, We had thousands of samples that were coming to the reference lab on daily basis, and this resulted in us having a backlog of samples and difficulty in dealing with the situation. So we set up to explore how we can take this molecular diagnostic system to areas that do not have the capacity to test. So the plan was to deploy a mobile platform for testing and to be able to also do surveillance at the point of need. So to be able to go to these places where they don't have testing available and support the testing. The plan is to design a system that can quickly respond to the outbreak. So even if you are based in Kumasi and now we are informed that there's a hotspot outside our region where we are, we can quickly move in and support the testing in those resource-limited testing. So I had the privilege of the president, you can see here, visiting my lab and asking us how we can do this because we were in quite a desperate situation. The plan at that moment was to look at the RPA option because that was the option that came to me at the point. But we have not really validated the RPA assay to be able to put a public health response. So we needed a PCR system that can work together with our mobile laboratory platform that we have, which together with Ahmed support, we have the mobile lab, we also have a glove box. And if you have a portable PCR system that can complement this, then we are ready to go on the field. So we got in touch with this company called Biomim in the US that had an FDA approval to use a portable testing platform to be able to support what we wanted to do. And this came at a good time because we had a support from American Leprosy Mission. What the STEM they had was a sample preparation kit that you can quickly put it inside the glove box and then extract your sample using this sample preparation kit. And it was very fast, it was very simple. In less than 5 minutes, the is done. Also have their kit already lyophilized in tubes. So as soon as you do your extraction, you transfer it into the tubes and it goes into this PCR machine called the Franklin. And this Franklin is operated using the mobile phone, so you can download the app and use it to manage the data on the PCR hardware. And so on the go, you can easily have your results and also through the cloud, transfer your results to a data center and report the data once you have it. So just to show you how this thing looks. So this is the RNA extraction system that they have. And you go through a series of, so each of this has different reagents inside. So here is your lysis buffer. The samples goes into it. You do, using a syringe, you do a 10-time pump in and out to extraction. And the syringe has a filter in it so that the RNA is trapped within the filter. You go through a series of washes, and then you dry here and then you elute. And once you elute, you have your go strips. You transfer the sample 20 microliters from your elution buffer directly into it, and it goes into the PCR machine. So the PCR machine, the portable PCR machine, has 9 samples at a time. And their assay is also such that is 2 targets. So it's the open reading frame 1AB and also the spike antigen or internal control to be able to, see whether your assay worked or not. And once it's set up, you can fluctuate via Bluetooth and then look at the results once the results comes up. So this is fairly easy, and also by the management of the center. Once the data is run and you synchronize. So we set up in our mobile lab. Our plan of thinking was to support the testing at the ports, as Prof Ma mentioned. That is one of the hotspots with travelers coming in. So in collaboration with the customs laboratory, they donated their van to us, and then we set up a van our glove box for sample inactivation and extraction. And then we have our portable PCR machine inside our in-house developed case lab. And the plan is that once the sample comes in, it goes directly into the glove box using the out vent here. The technician takes it inside, do the inactivation and extraction inside. And once it comes out, you just do the elution, add it into, it goes into the machine. And within a matter of an hour, the result is out. So what did we see after doing this preliminary result? So once we had this mobile setup in place, we took it to one of our hotspots in the Ashanti region. And so far, we've tested almost over 500 samples. And out of these 500 samples, we had a positivity rate of about 11%. And as part of quality control measure, 10% of these samples to test in the reference lab. And so far, we have 100% concordance. So it means that the system works exactly as the reference laboratory PCR system. The good thing is that we were able to reduce significantly the time that they take the sample, because this is at the point of, they take the sample right in the community, it comes into the van, we process the results, and then we send the results back to the health team, and then they're able to manage their cases. And this mobile platform, we realized that it was a good system to be able to decentralize in a safer way, to be able to detect COVID-19. And we think it's an innovative approach that we can upscale. And once we are part of the multi-center trial that are going to evaluate the RPA, once this RPA is validated, then we already have a system in place to get it moving if COVID is still with us. And it enabled us to respond quickly, and we supported the work of the health system. And also, as we do that, we were able to train the lab staff when need be to the Ghana health system. I would like to acknowledge my team led by Hubert, who Ahmed has met previously, and my team and the American Leprosy Mission. Through their collaboration, they were able to get the machine from Biomen for us. We also supported by the Anglo-Good Health Foundation, the region, able to do the testing, and also the Ghana Revenue Authority. Thank you very much, and I'm hoping for any questions. Thank you.
So many thanks, Michael, for to have to surprise us, and I must admit that you are one of the few countries which are producing the suitcase lab locally and develop it further to have now a PCR inside it. You didn't take my permission, but no problem. I'm just joking. Yeah. So Michael, so I would like you to stay with us, please, because we all the diagnostics directly after the next lecture from Dr. Haitham. He will have 10 minutes to give his presentation, and then we will have a diagnostic session where Manfred, Professor Ma, and you involved, plus Dr. Haitham, and then we can have all of you for discussing the diagnostic as one team. So stay with us. In 10 minutes, we'll come to you again for the question. Now I would like to ask Professor Haitham Amer to make his camera and his mic on, and then start to also share screen. So Professor Haitham Amer, he is the head or the chairman of the virology department, faculty of veterinary medicine in Cairo University, Egypt. He trained, I must admit, most of the people working in the virology currently. I have been trained by him in the first days of my life as a virologist. He went to Saudi Arabia to further train further scientists in an international atmosphere, and then he returned back to Cairo University, where he heading the virology department and continuing research from home. So, Professor Amer, the mic is yours. Please share your screen.
Thank you, Dr. Ahmed, for your introduction. Also, I have to say good afternoon for everybody. And it's really a pleasure for me to present our latest work on point of care testing in Egypt. This work just began from few weeks using SARS coronavirus kit for RBE detection. Of course, now all of us know that point of care testing is a very important issue that is currently increasing in popularity. By the way, point of care testing transfer all the lab testing outside the lab, which is very important nowadays. And in the case of epidemics, we can test just direct in open areas or in the bedside in hospitals, so that we can get many benefits from point of care testing, including speed of diagnosis and decision making, so that we can start treatment in the earlier time, and so that the patient outcomes improved. On the other side, it will help avoiding deterioration of specimens, because specimen after transportation, after preservation, after processing can cause or can suffer from many deterioration due to cellular metabolisms and temperature variation. Also, it make all the process very lean with much fewer steps needed. No transportation, no aliquoting, no coding, no processing, and also few or no communication of results, because the results will be taken at immediately. Also, the use of portable devices will help saving spaces in the laboratories and increase the flexibility and diversity of testing the different pathogens. In our work, we used RBE. Maybe I'm the last, but RBE had many discussions with Dr. Manfred, with Dr. Michael, and others. Recombinase polymerase amplification is a technology, is an isothermal amplification technology based on amplification of specific targets at room temperature, using 3 enzymes, namely they are recombinase, single-stranded DNA binding protein, and DNA polymerases. Many benefits can be got from RBE use, including time save, because all the tests will take 20 minutes maximum, so we can get the results in no time. Also, it's very economic, so that we can use it everywhere, and especially in low and medium income countries. The economy comes from the low cost instrument and from the affordable prices of the reagents. Moreover, it's very simple technique, can be adopted everywhere and need no training or just few training steps. Also, the test can be easily portable and could be integrated into suitcase lab, as Dr. Michael tell us about his experience in this regard. We can use it everywhere using solar panel or just power pack. Moreover, what help the portability of RBE is the reagents, which are available in a dry pellet form. So it need no cold chain and can be transported to any place, especially in hot countries. Our work regarding optimization and validation of RT-RBE assays for detection of SARS coronavirus 2 has started with Dr. Ahmed at the University of Leipzig for optimization of 3 systems based on sequences of polymerase gene, N or nucleocapsid gene, and envelope gene. And from his, sorry?
You have the share presentation?
Yes, yes.
Can you share screen, because your screen is not shared?
Oh, okay. Is it available now?
Yes, can you enlarge it, please? Yes, many thanks.
So again, for the 3 RT-RBA assays developed in collaboration with Dr. Ahmed in Leipzig, based on polymerase, nucleocapsid, and envelope genes. In the preliminary testing of the sensitivity of these assays, polymerase gene was the superior in sensitivity and detected down to 2 copies of RNAs, while the others are much less sensitive, but also in a good sensitivity range down to 15 RNA copies. We have used these 3 types of systems to optimize or to validate the assay on clinical samples from Egypt. We used 2 types of samples, archival frozen samples, about 18. Those samples were previously tested by real-time RT-PCR and stored at -80 for some time. And the others were fresh RNA samples extracted and tested immediately at once. And the number was 26. The whole number of samples are few because we just started this work a few weeks ago. Both samples were tested by real-time RT-PCR using polymerase enzyme gene sequences and the 3 systems of RT-RBA assay. For all samples were positive with CT values ranging from 15.5 to 22.7, which is high to moderate positive. For RT-RBA assay using polymerase sequence, all were positive, while for E and N, the assay results were not consistent. So we considered that the sensitivity of E and N need more optimization for the clinical sample in our case. For the frozen samples, here is the results of positive in comparison to the negative results. For the frozen RNA samples, all samples were tested before freezing and all were positive with CT values below 25. But when we retest these samples after thawing, the results were much less better than the first because the CT values ranged from 17 till 39.7. Moreover, 2 samples were negative. For the 3 RT-RBA assays, all were positive till CT cycle 28, but after 28 or in samples with CT values greater than 28, the results are not consistent. So that we can say that the clinical performance of these assays, especially the assay based on polymerase enzyme, is promising for use in point of need, while N and E genes need further optimization on clinical samples in our case. Also, it's very much better to use fresh RNA samples than to freeze these samples and rethaw it for use in assaying. Thank you, and I have to acknowledge the collaboration of Cairo University and Shams University and the University of Leipzig in this work, and thank you.
So many thanks, Dr. Haitham, for this nice presentation. So I will ask Professor Manfred, Professor Ma, Dr. Michael Frimpong to join us in order to take questions here. So please open your screen. So I would like to bring all of you now. And then Dr. Ma, you are with us from China. I'm sure that it's very late now in yours. So can you please switch on your camera and unmute, please? So that's good. So the other, please stay muted. Please stay muted for the others. We need to give a chance for everybody, for the speaker to tell their idea. So the others, please stay muted. So, or I will kick you out the meeting. And this is, I don't want to do it. So here, I would like to ask you the first question, because we started, so it goes to China, because this is, I have been myself asked, people ask this question a lot on myself. When we speak about RPA and REA, it looks 100% the same. So what your comment on that? What is the difference between these two technologies? You hear us, Dr. Ma, Professor Ma, do you hear? What you
Okay,
can,
yes,
yes.
got you.
What
Yes.
what is the main difference between RPA and REA? Yes.
Yeah, many people ask me the same question a lot. Repeatedly ask me the same question. What's exactly the difference between RPA and RA? So briefly, you know, RPA was invented in 2006 and RIA was 2016, 10 years later. This is, I mean, the time difference. Another difference is actually, I would briefly, the origin of the enzyme is different. RPA, all the three core components from T4 phages, while in RNA, they are from all of them from E. coli. In addition, the recombinase from E. coli has a function of the helicus, and that is different from RPA. I mean, the recombinase. The function of the recombinase is slightly different. One has a function of the helicus, one doesn't have. So it makes in some cases, we tried a lot, we tried a few of them. So in some cases, the RPA primers does not work well with the RAA systems. I bet vice versa. So the enzyme components of the enzyme is different, and the function of the enzyme is slightly different. I would say, is that answer your question?
Yes, this answer, but I think Manfred has a comment. I see his face. So Manfred, please go ahead.
Yeah, so if you go into the original patent of the RPA and look at the range of proteins mentioned in it, all of the proteins you are published in your papers, which are now the RAA, are already mentioned there. So as you know, patents are written with a big bracket. So as far as I can see it, all the proteins you're mentioning are in that bracket.
Yes.
Yeah.
Mm-hmm. So you could one dare to say, without being disrespectful, that the RAA is a better version of the RPA or a new version of the RPA?
I think it's 5 years ago, I tried RPA. I purchased from the British, from Oxford, from Swiss company. We have a salesman in China. So, and then I came close to meet with a Chinese scientist working in the RA company. So I also tried it. And so I have the chance to test both of them. So I realized that in the rack systems, they have a slight difference. Although I admit the principles is the same thing. But because of the components, the resource components, and the function of enzymes, so it still, in practically, the direction has that difference. I know the RIA has we have patent the RIA in China, and I know the RPA technology is already acquired by United States. So anyway, because I'm just a technical staff, so I really don't know if what happened if the RA meet with the RA USA. I really don't know, but from my academic point of view and from my own experience, I think RIA is good enough, at least in China.
Okay, that's good. I would like also to ask Manfred now. You speak, and also Professor Ma, you speak also about home testing and what is the importance of home testing. So can you comment, Manfred? Can you comment on what is the importance of home testing in the current outbreak, and what is the precaution we need to keep in mind if we do home testing?
So the current problem with the COVID-19 outbreak is that there is not enough testing available, and everybody focuses on the people with symptoms. So testing mainly focuses on people with symptoms. In fact, in Germany, which had a very good testing regimen, 2 weeks ago, all asymptomatic testing for asymptomatic patients was excluded, so they could cover those who are symptomatic. So if a home test were available, which could be used freely off the shelf from the supermarket or the pharmacy at an affordable price, then the picture changes. If it's a rapid test, which tells you on the day you test that you're positive or negative, and you consequently isolate yourself. There's been that paper by Larimore, which I touched on a few slides, explicitly shows that interval of testing and immediate isolation of positives has the greatest effect on taking infectious persons off the road, off the street. And you must be aware that 70 to 80% of all infections are asymptomatic, but these people transmit. So to catch those people, home testing would be a huge boost to controlling the pandemic.
So I will wend my question to Michael here and ask him that, because you applied the RBA in the field, and you have now a new technology from China, the REA, which you can use, and you applied now the real-time PCR. Always in this outbreak, we have realized that everybody, even the scientific community, said, okay, PCR is the Ferrari of everything, forget this isothermal amplification. And actually everybody said there has no market, this type of isothermal amplification. From your field experience, can you compare between what is the advantage and disadvantage of RPA and real-time PCR directly in the field settings?
Yes, so I think for us in lower middle income countries, the important decision for any public health service or any government take a decision is cost. So cost and availability is two key things. And that has been the driving force for any intervention that the government will want to put in place. And what we've realized with this pandemic is that because the bigger players are highly affected, I mean, they are even struggling to deal with their own situation. It makes it very difficult for it to trickle down to us. And so if we have these interventions that are available to us, if we have the RPA that are available to us, then that becomes something that we can use in the absence of the PCR. And that is what we've seen, because in the heat of the pandemic, when we around the June, July, August, we had a problem with even getting the reagent to be able to do the test in the reference laboratory. The PCR assays were not coming in. And that is where then you have to fall on the alternatives that we have. So for us, the plan of using the RPA is not to replace PCR, but have an alternative in place. And also because we don't have the laboratories and the setup to be able to properly do the PCR as has been designed to do, then the RPA becomes an alternative. Because, like I said, in Ghana, only 2 labs were properly planned and well functioned to be able to do PCR in the right sense of it. So the RPA or the portable system then become an option to be able to spread out to these local communities, resource limited setting. And that is where we see the advantage of the RPA. And in our work with neglected tropical diseases, that has been the focus, because then we have a system that get the results for the patient to be able to get the right treatment or management. So that is where I see it. And I think that the RPA or RRA, whichever way works for us, has, some kind of a place in, especially in lower middle income countries. Thank you.
So thank you, Michael. So the question goes to Dr. Haitham. How you think, because you have tested many samples and the results was not continuous. So what do you think about what is the effect of the type of sample, and what is the effect of storage and DNA RNA extraction on the results quality at home? Dr. You need to unmute first, please.
Okay. We have to say that we are in the first step for validation of these assays. We have tested only about 44 samples. So we need to test more samples and to evaluate different samples and different sample conditions for all assays. So these results are preliminary, but we have to mention that all the tests done on frozen samples has resulted in much worse results. So, and when we compare these results in real-time PCR before and after freezing, the results vary from 5 to 10 cycles, so that we can consider storage a bad condition for using these samples for testing in the RT-RB assays. But I know well that we need to test more samples to get a complete vision. Thank you.
Ahmed, you're muted. Ahmed, you're muted. We can't
Sorry.
hear you.
So Professor Ma, so what I would like to ask you is that now, if you, because you evaluated and did clinical trials for point of need diagnostic, what is, from the China perspective, what do you think is that the minimum requirement to give an approval for a diagnostic test, either for point of care or for home testing?
So basically, the minimum requirement of the Chinese FDA in terms of the sensitivity is 1,000 copies per ml. And also, China FDA has an internal quality control panel to test the specificity of your kits. It's composed of lots of the respiratory pathogens other than COVID-19. So if you passed this internally control panel, means if you can tell the true negatives, the true positives, and meet the minimum requirement of the sensitivity, which is 1,000 copies per ml, then it's and it's gone, and you will have the approvals. But before that, you have to have at least 5,000 samples, clinical samples from 3 clinical centers to comprehensively evaluate your clinical performance by comparison with commercial real-time PCR kits. So, although we have approved like 25, nucleic acid-based kits, but few of them are isothermal, application assays, because in China we have a very, very huge pressure from the importing goods or from at the customs. So in this case, we are really highly demand the rapid testing kits in China. And we all know that the antigen testing is really fast, but with with very low sensitivities. So they are not good enough to be applied in customs. So as to the POCT, in China, I think the main problem in China in terms of POCT, liquid acid POCT is throughput. In China, so far we have only like liquid acid based POCT with 1 to 4 samples per run, which is not good enough to meet the requirement at the customs. So that's been challenging. But I think the thermal-based assays, I think it will fit these sightings somehow, particularly at the customs, because the timing is really is highly demanded at the customs. We are trying to set up a scenario in which we set up a portable detection device, portable detection areas with a portable machine at the front, just at the airport. When packages comes in, they will take samples. We calculated roughly, like if we have 6 persons, 2 sets of the RNA machines, we can easily finish 200 samples in 2 hours. So I think it makes sense. So I think basically it's I think that's exactly what exactly the isothermal assays like RNA will fit best at the customs. And another thing is at the country level, the fever outpatient unit, where there are resources limited with less skillful personnel. They do need a simple method such as RNA, because they have no idea of the PCR at the country level in China. So I think these 2 settings are best suitable, for the applications of the RNA. Thank you.
Okay, so many thanks, Prof. Ma. So Manfred, I would like to ask you your final remarks, especially on you did a lot of outbreak investigation and you did a lot of implementation of diagnostics, starting with PCR lateral flow assays in many African countries. And I would like to tell you what's your feelings, how this diagnostic can affect the lives of the people in remote area, for example. You are unmute, please, Manfred.
So I think that's a very general question, but I think I'll answer it with an example. When the Ebola test was used in Conakry at the end of the Ebola outbreak, the local administration decreed that all dead had to be tested. And 2 suitcase labs were placed in a morgue and in a hospital, and the safe and dignified burial teams were scouring the area for dead people to be tested. So when the community realized that a rapid test was available with results issued after 30 to 40 minutes, they actually engaged with the process. They indicated their dead to the safe and dignified burial teams. Like, look, here's my granny, she died last night. She didn't die of Ebola, just test her, I want to bury her. So the speed of the result, the time to the result, can have an effect on the engagement of the local population. I mean, Ebola is a drastic example. If you deal with other diseases, you also need engagement from the community. And I think in cases like Michael described, where they're taking out point of care systems, be it PCR or RPA or whatever, to areas where there are no infrastructures, there's no labs or no provision of testing, the local population will always appreciate the availability of testing at all. So it's about taking out the test to areas where there is a need, so the point of need. I think that would be a suitable reply.
Thanks, Manfred. I will go now to Michael. So, Michael, you have done a lot of tested for coronavirus, and also you are a specialist in neglected disease. Do you see an effect of this outbreak on your neglected disease control programs in Ghana?
Yes, I mean we've seen a massive effect on the NTDs front, because all the attention now has moved to COVID support. So most of the teams we have in the field, or the nurses and the community volunteers that we use for looking for case search for neglected tropical disease, are now also being used for contact tracing for COVID. So this year it has been a major impact on NTD work as a whole, but we believe that we are still working the system, and once COVID is dealt with, we might have to put in extra efforts to get the work done. But we will not relent on our efforts. We will get to it, and we hope to bring it back to the forefront. Thank you.
Okay, many thanks, Michael. Dr. Haitham, I ask you to unmute, and I would like to ask you a very important question, because since you are work with diagnostic point of need and PCR, so why we didn't see too much data on diagnosis of COVID-19 in animals in Egypt? We have seen a lot of MERS coronavirus diagnostic in the last few years in Egypt, but when it's come animal and COVID-19 testing, the data is very rare. What's your comment on that?
Yes, you're right. But I have no explanation why all colleagues didn't work in this regard, but maybe the availability of the samples and the organization between the pet animal clinics or farm animals, if we consider them, with the researchers. But maybe since a few months, many groups in different Egyptian institutions and universities start work on many animals, especially on pet animals. And we expect that something will be in the track in the next few months.
Okay, many thanks, Professor Haitham, for this. So I ask this session, the leader of this session, the speaker, Michael, Haitham, Ma, and Manfred. Many thanks for joining us. Many thanks of giving insight on the REA, RBA, hydrothermal, your lab in a van. Michael, this was a great experience. Many thanks. And Haitham was exploring that one gene is not enough. This must be several genes. You need to test it locally in your country and see if it's working, because some people say it's working very good. It's a very nice publication, but once you try it, it does not work as it's mentioned. So it's very important to have also the right sample to test your or validate your system in order to reach a good system. We have learned from Manfred that asymptomatic patient is very important for this outbreak, and diagnosis with PCR. We need to look very deep into how the results look like. So thanks for all of you. Now, what I would like to do this is now the end of our meeting. I ask everybody to open the camera, but not the mic, only the camera, please. I would like to take last remarks from Professor Shalaby as the head of the Egyptian Society of Virology. So please, Professor Shalaby, say a few remarks at the end, and then we will end the meeting.
My remarks on the rapid testing of COVID-19, I saw in our area that the market monopoly of some companies using PCR don't recognize us at all. They rejected to use these new techniques. And this is, you know, the monopoly of some companies. And that is why only 105,000 sample was tested only for COVID-19. If they permit to use, as Dr. Manfred mentioned, to be used in far districts, small districts, railway, airports, and you know, we have some area, rural area, and the expensive of the testing is very high. And everyone should pay in advance to make the testing. And they didn't allow the private sector to use or to test, only for the governmental laboratories. And this is what we asked many times, to allow the private sector under some certain circumstances, under control, give them the procedure to be unified all over the country. That's why we have a limited number of samples tested by using only PCR. That's why we, through this very interesting symposium, that we can make it as a conclusion, or maybe as remarks to expand the point of care testing, and to try to convince, if this techniques was recognized by FDA or European market, I think it will be expanded and so on. Finally, I am very proud for this symposium, which included many eminent scientists, also a group of participants from every country. You know, in Egypt, you know, we have more than 100 participants, but we localize them in one link. You know, we have three links. Not all the people appear in the number you show now. So because we, as you said, we should give a chance for many people to participate. I think this is a very successful meeting for the Egyptian Society of Virology, and one of the activities. By the way, I would like to say for Dr. Manfred, hi, Dr. Manfred. I'm happy to see you again back to Germany, because Professor Manfred visited us 2 times, I think, or 3 times, and he aware of our circumstances, and he helped us a lot in the, not only for the diagnosis of foot and mouth. Don't forget also H5N1 and H9N2 influenza virus. He participated for supervising one of the doctor theses with us and one of our students now. And thank for all the participants, for all colleagues from United Kingdom, from China, from India, from Ghana, and I think also from Egypt. Thank you for all, and we hope that we can repeat this symposium And I think I was very afraid for the success of this at the beginning, but now I'm very comfortable. And thank you, Ahmed. Without your help, I think we'll have a lot of problems. Thank you, and thanks also for Leipzig University to give us this time for the link for 24 hours. Thank you very much, and thank for all the participants. Thank you. Goodbye. You are on mute, Ahmed. We didn't hear you.
Everybody, please open the camera. We need to see the faces. So it was a very nice journey this morning. We have a very nice how you can support outbreak investigation and 2 international cooperation with Daniel Bausch. Then we moved what is the situation in Egypt with Dr. Ghada, who gave a very good outline what's the situation in Egypt and we need more testing. Dr. Mohamed Munir, he gave a nice presentation about the vaccine and how we can really work hard to have the vaccine for everybody. Mitali have told you that there are other diseases, not only COVID-19. Manfred give you an overview why diagnostic is important and how you evaluate your data of diagnostic, not take it only as positive, negative, and that's it. Professor Ma from China has really give us an insight about the new stuff coming from China, the REA, and how it can be also compete with RBA and other hydrothermal amplification to do more testing. Michael, a very great scientist from Ghana, who tell you how he can take your van to remote area to reach, not sending the sample to the lab, but really taking the lab to the point of need, as Manfred mentioned. And finally, Haitham has given an experience how you evaluate the test locally and have your own results and don't depend always on the catalog of the companies. So it was a very nice journey from all of you, and I'm very happy and proud that all of you see now. So I will take a screenshot with all the faces. Please smile. George Adimov, you need to open your camera. George. So I think Giorgio, it's very important, George, from Nigeria. Please start your camera. Yes, George is starting. So we see a lot of faces, some with mask. We see faces, Martin from Senegal here, they are standing. Wissal from Sudan, and we have our colleagues from Egypt, Shalendra from Sri Lanka, welcome that you stayed with us. Freda from Germany, George Adimovo from Nigeria just joined us. Also the Egyptian living in the UK, Mahmoud, they are with us here. And then also the Dr. Ibrahim here from Saudi, he's asked us, I don't want to mention all the name here. Thulsi has asked a lot of questions during the meeting from Mansoura University. So I need to take the photo. Then next page, we have the very nice faces. Yeah, so I see that the second page, nobody opened the camera. So Tramona, Ria, Ala, Wala, Amira. So we have no faces in this area. So if you are with us, please open your camera that we can have a group photo. So we take it. So everybody, I'm happy that I coordinated this for you. I hope you enjoy it. We have here people from many countries, starting from China to Germany and going very down until Ghana, Nigeria, and our friend in Sudan. So stay safe and many thanks for joining us. See you next time. Bye-bye.
Bye-bye. Thank you, Ahmed.